providing you with breakfast and lunch if you signed up for it, and all the materials. Be sure you have the blue book. John, can you go get the blue book so that everybody knows what the blue book looks like? There's also other materials out there. I'm wearing a bracelet and I have a pin on my jacket, and you're welcome to help yourself to those supplies that we have. Anybody need a blue book? Okay. And if you didn't see the supplies on the supply table, please go and get some at break time. Okay. I just thought you'd like to know we used to have our first meeting was in March 2004 in Dallas, Texas. 2004. So that was the first ASG meeting, and they had many of them, sometimes as many as 50 meetings a year. And that was a lot. Muriel Finkel from Chicago is the one that started the ASG because she took care of her uncle and he passed away from amyloidosis, and nobody knew what it was at that time. And so she thought she would start these support groups. And John and I have signed up. I signed up way back in 2006. And when did you sign up?
10 years ago.
10 years ago.
My first meeting was here in Seattle.
Aha. Okay. So since COVID, she started doing a few webinars, and those are posted on Facebook and YouTube. And John and I just do the Pacific Northwest meetings of Seattle, Portland, and Spokane. And you're welcome to attend any of those if you want. How many years have you been in remission, John?
10.
10 years. That's pretty good.
Complete response. Thank you.
How many years have I been in remission? 24. So I think we will, do you want to start the video, or do you want
I've got a couple of pictures because I've been getting a lot of questions. Everybody's wondering what I've been up to, but just real quickly, this is the blue book. There's more out front if you need them. The video is also posted online, so if you have family members that couldn't make it today, you want to share some information, it's a real easy, approachable way to get that information. It's always disturbing to see yourself. I really brought these for you, Kay, so you need to look up here, Kay, because she's been pestering me for more pictures. I made a trip recently, but pop quiz, a couple of you may remember where I was going, but I'm going to give you some hints. That's your first hint.
Sally Lightfoot crab.
See? That is a blue-footed booby. Has anybody seen a pattern yet?
Yes.
This is the penguin, little tiny little guys. Giant tortoises. Okay, well, there you go. Yep. I was in the Galapagos. So short little video, but it was, it's not playing. But it's basically this, but it's moving. So I got to do that 2 months ago. I got to sail out of Costa Rica to the Galapagos. Somebody at a previous meeting asked me why I did it, and somebody else before I could answer said because I can. I'm able to, so that's kind of my adventure thing. I was talking to Bob earlier. I'm sailing from Iceland to the Faroe Islands to Shetland this summer, and then me and my family in Scotland. So there's lots of promise and lots of opportunity for us here. We have specialists like Dr. Cicero that can make amazing things happen for us. So that's it. So short video for you.
Amyloidosis awareness. Throughout our lifetime, our DNA codes for the production of small molecules called proteins. These proteins provide the structure and function for nearly all of life's biological processes. Once proteins are made in our cells, they naturally fold into a particular shape. This shape allows for their specific function in the body. When proteins are folded properly, they work as they should, and we enjoy good health. When proteins are misfolded, it can impair our body's normal functioning, and problems may arise over time. Our bodies are usually pretty good at identifying and removing abnormal proteins. In some cases, though, we either produce too much of the abnormal proteins for our bodies to handle, or we're not able to break down and clean up the proteins at all. Amyloidosis is just one class in a growing list of protein misfolding disorders. While there are many types of amyloidosis, in all cases the misfolded proteins called amyloid, meaning starch-like, take on a particular shape that makes them very difficult to break down. Because of this misfolding, amyloid proteins bind together to form rigid, linear fibrils that ultimately build up in our tissues and organs. Depending on where the amyloid accumulates, such as in the kidneys, heart, nerves, or gastrointestinal tract, different symptoms become apparent as those organs are affected. Left untreated, amyloidosis is life-threatening, so early, accurate diagnosis is key in promoting positive outcomes. Currently, more than 25 different proteins have been identified that can lead to amyloidosis. The many types of amyloidosis can be classified according to the precursor protein that is misfolding. A simple naming system is used, such that the prefix A refers to amyloid, followed by an abbreviation for the protein underlying the condition. In AL, or primary amyloidosis, the amyloid is derived from misfolded light chain antibodies. White blood cells in the bone marrow, called plasma cells, are producing too many defective light chain proteins. The kidneys, heart, liver, GI tract, and nerves are most often affected. In AA, or secondary amyloidosis, the disease results from increased levels of circulating serum amyloid A protein. The body produces this protein as a natural response to chronic infection or inflammation. The kidneys and liver are the main sites of amyloid deposition. In ATTR amyloidosis, the amyloid originates from the Transthyretin protein, which is produced in the liver. In hereditary or familial forms of the disease, there are more than 120 genetic mutations already discovered as contributing to amyloid formation, which primarily cause nerve damage and heart problems. A non-hereditary form of the disease, known as wild-type amyloidosis, results from TTR amyloid building up in the hearts of the elderly. Whether caused by genetic factors or increasing age, TTR-mediated amyloidosis is actually thought to be more common than AL amyloidosis, though it often goes undiagnosed. Amyloid also sometimes deposits in isolated areas, such as the bladder or airways, without evidence of a systemic disease. These localized tumor-like deposits are made up of light chain proteins, similar to AL amyloidosis. In this case, the plasma cells producing the amyloid are in the affected tissues, not in the bone marrow. Many physicians will not expect to see amyloidosis in their clinical practice. Yet, for example, because TTR amyloid is often undiagnosed in patients with heart failure, it's very likely that the disease is much more prevalent than now recognized. The symptoms of amyloidosis are usually vague and nonspecific, such as weight loss, fatigue, shortness of breath, foamy urine, swelling of the ankles and legs, numbness or tingling in the hands and feet, as well as carpal tunnel syndrome, lumbar spinal stenosis, and bicep bunching. Because these symptoms mimic those of other common conditions, often being mistaken for heart, lung, or kidney disease, it's not uncommon for a patient to see several physicians before a biopsy is taken. But if there is kidney, heart, nerve, gastrointestinal, or liver disease with no obvious cause, it should absolutely prompt physicians to test for amyloidosis. As part of the differential diagnosis, the 4 most common clinical settings in which amyloidosis should be considered are 1. Loss of massive amounts of protein in the urine. 2. Stiff or thickened heart. Low voltage on electrocardiogram, irregular heartbeat with normal or low blood pressure, or unexplained heart failure. 3. Enlarged liver without alcohol consumption or other explanation, often with abnormal liver blood tests. And 4. Numbness or pain in the fingers or toes, carpal tunnel syndrome, or alternating bouts of constipation and diarrhea while also feeling lightheaded when standing up. While non-invasive imaging such as echocardiogram, cardiac MRI, or pyrophosphate scan can be an important tool, the gold standard for detecting amyloid deposits is to employ Congo red staining on a tissue sample. The easiest way to get a sample is to aspirate fat from the abdomen, like a mini liposuction. Amyloid has a pink color when dyed with Congo red, and a characteristic apple green birefringence when viewed with a polarizing microscope. This signature technique is able to diagnose AL amyloidosis in 70 to 80% of cases. If the fat pad aspirate is negative for amyloidosis, but suspicion of the disease is high, a direct biopsy of the involved organ, for example the heart, kidney, or liver, should be done. If amyloid is present, the use of Congo red staining will yield a definitive diagnosis in nearly 100% of cases. Viewing the tissue sample with an electron microscope will also show the classic structure of amyloid fibrils, thus confirming its presence. Proving that amyloid is present in an organ is only the beginning of the process. Next, the type of amyloid causing the disease must be determined in order to plan for an appropriate individualized treatment. Recent advances in the field of proteomics promise to revolutionize the precise diagnosis of amyloidosis. Laser microdissection of Congo red positive samples, followed by mass spectrometry, is the premier technique in typing amyloidosis. LMD-MS can be performed on any tissue sample, including a fat pad aspirate, if amyloid is present. Studies have shown that LMD-MS can identify all known amyloid proteins with virtually 100% accuracy, as well as characterize new ones. All in all, with the possible exception of an enlarged tongue or bruising around the eyes, which are seen in a small percentage of cases, there are no telltale clinical signs of amyloidosis. However, regardless of a patient's symptoms, because of the unique staining and spectroscopic properties of amyloid proteins, it is a simple matter to test for the disease. Early and precise diagnosis is essential for patients to benefit from the many treatments now available. Depending on the type of amyloidosis, treatments may include chemotherapy, cardiac care, organ transplantation, or targeted drug therapy. In each case, the aim is to reduce or eliminate the supply of amyloid protein so that organ function can improve. There are 3 general approaches to disrupt the formation and deposition of amyloid, which vary according to the type of amyloidosis. The most common treatment interferes with the production of the precursor protein, leading to the disease. The second method uses drug therapy to stabilize the normal structure of the precursor protein, thus preventing it from misfolding into amyloid. The third strategy targets the amyloid directly, both circulating in the blood and deposited as fibrils in the tissues. By tagging and destabilizing the amyloid, one's body can potentially identify and remove the abnormal proteins more effectively. Given the complexity of the disease and that each case is different, it is recommended that treatment be performed in a medical center which has experience with amyloidosis. Alternatively, patients can have an initial evaluation at such a center with continued communication during treatment in his or her local community. For a free illustrated booklet that explains amyloidosis in more depth, please visit amyloidaware.com to download your copy and share with others.
Okay, if there are any questions, you have a panel of wonderful doctors that are showing up today. Did you want to say something?
Yes, I'd like to introduce Dr. Kara Cicero. And before we start, I'd like to know how many of you have cardiac involvement. Please raise your hand if you have cardiac involvement. Quite a few of you. Okay. How many of you have renal involvement? Okay. A few less. Okay. How many have both? Both cardiac and renal. Okay. And how many have nerve? involvement? Okay. And how many have GI involvement? Isn't this amazing? Thank you. How many have had a stem cell? A few. They're not doing it as much as they used to. Any of you on CyBORD, DaraCyBORD? Quite a few of you. Okay. So we have a very tight schedule today. All the speakers are given 15 minutes to speak. We have a little bit of time for Q&A. So in your folder, we have evaluations, I believe, and so please remember to turn those in. So we'll start with Kara.
Thank you. Sure. All right. Hi, everyone. So I'm Cicero. I see a lot of familiar faces, and it's really great to see y'all here. Thanks so much for sharing your Saturday morning with me. I am one of the myeloma oncologists, plasma cell disorders oncologists, that has a special niche in treating and managing AL amyloidosis. So today I'll be speaking about treatments for AL amyloidosis, and then we'll have a couple other oncologists follow. So Dr. Zonder will be talking about immunotherapy, and then Dr. Dhodapkar will be talking about the exciting new kind of therapies that we are growing here at Fred Hutch. Here are my disclosures. And so we'll start by just delving into the background. The video did a great job of talking about what AL or amyloidosis is in general, but I'll just highlight again the pathogenesis for AL. I think it's really important to understand what's happening in this disorder to understand why and how we are treating it. Then I'll move on to plasma cell-directed therapies, just touching on the most common things that we think about these days. There's a lot that is available. And then we'll talk a bit about unmet needs. So in terms of what AL amyloidosis is, as I'm sure that many of you know, it is a plasma cell disorder. So again, from the video to highlight a couple of the key facts, plasma cells, type of white blood cell that's created in our bone marrow, and they are our antibody factory. So they create antibodies to fight against infections. That is normal, and everyone has plasma cells. What's happening in plasma cell disorders, here it says multiple myeloma cells. That is not what we're talking about today, but that's a more common plasma cell disorder. In plasma cell disorders, what's happening is plasma cells replicate. Instead of creating all different types of antibodies, they create one abnormal protein over and over again. And essentially what this abnormal protein is, it is an abnormal antibody. So an antibody, or an immunoglobulin is another term for it, is comprised of a heavy chain and a light chain. In AL amyloidosis, the problem comes from the light chains, which have a tendency to misfold and form these amyloid fibrils. And what happens with these amyloid fibrils is that they can't circulate around the bloodstream and instead turn into insoluble fibrils that can have the potential to deposit in certain tissues throughout the body. And so here is a sample of what it looks like for those fibrils for deposition. And so as the video did a nice job explaining, and I won't go into details, depending on where the fibrils deposit, people can have a huge variety of different symptoms. The most common organs that are involved in AL amyloidosis are the heart, the kidneys, the liver, nervous system, but really any organ system can become involved, each of them having very different, vague symptom manifestations. And so therefore, one of the big issues with diagnosis is the delay these days. And so when we think about treatment, what is currently available is plasma cell-directed therapies. The aim here is that by targeting the plasma cells, those abnormal cells that are producing the abnormal proteins, we can eliminate those and shut off the production of the abnormal proteins by hopefully then allowing no further deposition and allowing the potential for the organs to recover. And so the goals here, ideally, to get a 50% reduction in your free light chains by cycle 2, get a greater than 90% reduction by cycle 4. And then the goal, the real ideal would be to get normalization of the free light chains, as well as no abnormal protein seen on electrophoresis and immunofixation by cycle 6. And again, by these measures, we're then seeing the abnormal production no longer being produced. What's really incredible is that we've come a really long way from where we were, several years ago. So in the 1980s, when we didn't have any really effective treatments for AL amyloidosis, the median survival was less than 1.5 years. Now, people that have cardiac complete responses have normal life expectancies. And one of the most important things to achieve a cardiac complete response is to get a good and deep hematologic response. And so Dara-Cybordi really is the standard of care these days for frontline treatment of AL amyloidosis. And this is based on a trial called Andromeda that was published in 2021. What's really incredible is that this is the first and only randomized trial in AL amyloidosis that has led to an FDA-approved regimen. And so Dara-Cybordi, again, is the standard of care these days. Based on this trial, what this trial was, it was a randomized phase 3 clinical trial that looked at cyclophosphamide, bortezomib, and dexamethasone with or without daratumumab. And it enrolled 388 patients with newly diagnosed AL amyloidosis. About 2/3 of these patients had 2 or more organs involved, 70% had cardiac involvement, 60% had renal involvement, but really importantly, the most advanced patients were excluded. So those with Mayo Stage 3B or 4 disease, as well as those that had a glomerular filtration rate less than 20 were not eligible to participate. And in those that did get the daratumumab, cyclophosphamide, bortezomib, and dexamethasone, after 6 months, 53% achieved a hematologic complete response. And this signaled about 42% got a cardiac response, and 53% got a renal response after the 6 months too. Importantly, though, organ responses typically lag behind the hematologic responses, with the best cardiac response seen in a year after starting treatment. Those that have a cardiac complete response, this usually takes 1.5 years. The best renal response takes usually 1.5 years. Those that achieve a renal complete response usually takes 2 years. And then liver response usually lags behind the most, about 3 years. And so in 2024, a 5-year follow-up of Andromeda was published that showed 41% of people after 5 years did achieve that cardiac complete response. So a lot, of improvement since where we were decades ago, but still a ways to go. And so for those that are not able to get the complete response after 6 months, after 6 cycles, what are our options? And this is really an unmet need in terms of how best can we work on deepening responses, and what are our other options for standard treatment thereafter. And so we think about venetoclax as another option. And so prior to Andromeda, a lot of our regimens used for AL amyloidosis were really based on multiple myeloma trials. We know that AL amyloidosis is incredibly rare, 9 to 14 per million, and multiple myeloma is more prevalent, and so a lot of the lessons that we take from amyloid have initially started there. And one of those trials was called Bellini, which was basically looking at venetoclax, the addition of venetoclax to a backbone of bortezomib and dexamethasone. And what it's found was that venetoclax plus bortezomib and dexamethasone improved the progression-free survival compared to bortezomib and dexamethasone alone. However, it decreased the overall survival compared to bortezomib and dexamethasone alone. And so it had a better response duration, but worse survival. And the summary or the conclusion was that there was too much risk compared to the benefit for venetoclax due to unfavorable toxicities, mostly due to grade 5 or fatal infections. This is a whole list of all this, adverse events that were reported. Basically, the most important things that I wanted to highlight is that grade 5 is those that lead to death, and a lot of those were infections in the venetoclax arm. But what was really interesting about this study was that there was one specific subset, those with translocation 1114, which is a genetic marker within those plasma cells that is a driver mutation for the development of plasma cell disorders in some patients. that did lead to better responses and survival, in addition to the progression-free survival. So if you look at hazard ratios, or basically if it's greater than 1, then there's more risk than benefit. If it's less than 1, then there's less risk than benefit. And so if you look at the patients with translocation 1114, there was about a 40% reduction in the risk of mortality overall. And so when we think about AL amyloidosis, 60% of people with AL amyloidosis have a translocation 1114. So it's a really good other option, if someone doesn't have a good response to Darasibordi. And so there hasn't been any prospective trials looking in AL amyloidosis for venetoclax randomized specifically, but this was a retrospective cohort study looking at 43 patients with relapse refractory AL amyloidosis throughout 14 centers from 2009 through 2019. And they did find a hematologic complete response in 41% of people. And in those with translocation 1114, there was a 12-month progression-free survival of 90%, an overall survival of 97%, and importantly, this benefit held for those that were daratumumab refractory. And so going down our list, well, what happens if someone is in that 40% of so that doesn't have a complete response to Darasibordi, and they don't have a translocation 1114? Well, there's a lot of other options for plasma cell disorders. A lot of them, again, taken from the myeloma insights that we have. But transplant historically has been something to think about. And so looking at the data for transplant, what we're talking about here is autologous stem cell transplant. In other words, high doses of chemotherapy with your own stem cells as a rescue. And so this study was the only randomized trial for AL amyloidosis using transplant that has been published as of yet. And it was published in 2007, so quite outdated. And so what this looked at was 100 patients that were younger than 70 who had received no more than 2 prior lines of therapy. And whether or not they had transplant, they actually got a similar hematologic response. But really importantly, the transplant-related mortality was 24%, which is incredibly high. Since that time, though, there has been so much that has changed, including bortezomib became available in 2005. Now daratumumab is being used, so really, really deep responses that we weren't seeing, allowing for better organ responses. And then there's more selective criteria for transplant in general, looking at not only frailty and age, but also organ function. And so over time, you can see that the pie charts are all reflecting responses, hematologic responses, and the line chart is reflecting mortality rates. And so over time, the use of transplant hasn't necessarily changed the rates of hematologic complete responses, but it has significantly decreased the mortality rates just due to the use of transplant over time, not necessarily using transplant versus no transplant. And so now these days, the mortality rates are about 2% for those that do have transplant. Again, still pretty high when we do have other options that might not carry that same risk. So there is an ongoing trial, SWOG study S2213, the aim is to look at these days with Darasibordi, now the standard of care, is there a role for transplant at all? Because most of us have really moved away from using transplant for AL amyloidosis unless we are unable to get an optimal response with other non-transplant approaches. The caveat there is if someone has multiple myeloma and there's an overlap, but that's outside the scope of this talk. Okay, so a couple of words on unmet needs. Well, one of the biggest things is that all of our therapies these days are targeting those plasma cells. And again, what I mentioned before is that one of the biggest problems with the amyloid is that there's a huge delay in the diagnosis. And so oftentimes when people are seeing us, they already have pretty significant organ involvement. And the more that the organs are involved at diagnosis and initiation of treatment, the harder it is to kind of regain an organ response later on. And so there had been an interest in antifibril therapies. In other words, can we take out the deposits that are already there rather than only aim to shut off the production of abnormal proteins? And unfortunately, last year was a pretty disappointing year in terms of these clinical trials. First, the AFFIRM-AL trial had a press release, and this was looking at birtamimab in a phase 3 global clinical trial, which is an antiviral therapy. Again, its aim is to take out those deposits that are already there. And it was looking at the standard of care with or without birtamimab, looking at 207 patients across over 140 centers with the most advanced stage 4 AL amyloidosis. However, last May, Prothena, which was the company that was developing this, announced that it did not meet its primary endpoints, and so therefore the development was discontinued. And the primary endpoints was time to all-cause mortality, 6-minute walk, and then the secondary ones that they also looked at was 6-minute walk test, physical component score. And so if you look here, none of them met statistical significance, which is pretty disappointing. That said, it was generally safe and well tolerated. Then last year in July, there was another study that came out looking at anselamimab, which is KL101, another antifibrillar therapy. This trial, CARES, was 2 actually parallel trials looking at, they were also phase 3, they were also global, and it was standard of care with or without anselamimab. The parallel trials, one of them looked at stage 3A, the other one looked at stage 3B amyloidosis, so still advanced disease. It looked at 271 patients that received at least 1 dose. 271 received at least 1 dose of anselamimab, 134, 1 dose of placebo. It was a 2-to-1 randomized trial. And so here the primary outcome was a little bit confusing. It was a hierarchical composite. So first they looked at all-cause mortality, and then if people were still alive, then they moved on to including the frequency of cardiovascular hospitalizations. And they did say that they had a pre-specified subgroup analysis by light chain subtype. So importantly, last July, another press release came out, and it said that it did not meet statistical significance for the primary endpoint in the overall patient population. But they also left this kind of cryptic message that said that there is a highly clinically meaningful involvement with anselamimab in a pre-specified subgroup, and they didn't really give us much more information at that time. Well, just a couple of weeks ago, we learned, and the safety data was very comparable. Well, just a couple of weeks ago, a paper was published that actually gave us more insight into what that subgroup looked like that might be a bit hopeful for the future. And so this was specifically looking at the kappa light chain subgroup. And unfortunately, the thing here is that kappa light chain affects about 20% of people with AL amyloidosis, so the majority is lambda. But in this trial, 62% of people did have a significantly reduced reduction in all-cause mortality that had the kappa subtype. 71% had a reduction in the cardiovascular hospitalizations, also meeting statistical significance. Importantly, that composite outcome, again, all-cause mortality to cardiovascular hospitalizations had a favorable trend, but did not meet statistical significance. So there's still a lot of questions with this kind of analysis as well. The thought here is perhaps there is higher affinity to binding to kappa, and that there's actually a difference when we think about the antifibrillar therapies. Yes, the last stage this is the last thing I have, and this is just the clinical trials that we have here at Fred Hutch, because clearly there's a lot of unmet needs. So currently open for recruitment. We have a bispecific trial that's in the relapse setting. We have, in startup, we have a trial that's looking at CyBorD with a BCMA-targeted antidrug conjugate. That's belantamab mefadodin. Under consideration, we're thinking about a bispecific trial versus CyBorD in newly diagnosed setting, as well as a dual CAR for relapse refractory. And then just to highlight a couple of the trials that we have had here too, we did have Andromeda here, that was the major CyBorD trial. And then we also did have the KL101 and the AFFIRM birtamimab trials. So just like a little bit of a highlight of what we have. This is always fluid, but trials are really important to us. And that is all. So I'll pass it over to the next speaker.
Thank you very much, Dr. Sarah. Next, I'd like to introduce Dr. Jeffrey Zonder. He's from Carmenos, which is near Chicago. He will be online. Welcome.
Hi. Can you hear me okay?
Everything is great. Welcome to Seattle.
Thank you. I appreciate it. So to be clear, Karmanos Cancer Institute is actually at the Detroit Medical Center. We're the only comprehensive cancer center that serves Southeast Michigan, Detroit area. The Seattle, I wish I was able to be at the Seattle meeting in person. It's a meeting I've been to a few times over the years, and it's always a great meeting. My job, I'm going to share my slides. Let me know if you can see them okay. Can you see them? Good.
Yeah, for a moment.
For a moment. There you go. What about now?
Oh, good image of you.
Oh, good. That's not very helpful. Okay. Let's see. When I tried to share my slides, let's see. Let's try again.
Swap the screens, Jack.
Are you seeing my slides?
Yes.
I'm going to try to turn them into a slide presentation again. Let's see if that works. Nope. It went out on us. That's not good. All right, but we can do it. We can do it a different way. We'll do it.
Dr. Zonder's been to many of our Pacific Northwest meetings. All
Is it
right.
working? Wow. Okay. I did the same thing 3 straight times, but it worked the 3rd time. Fantastic. Okay. My task is to talk about newer classes of antibodies and another newer immune type of therapy called CAR T cells, which is a cellular therapy. In terms of disclosures, I just want to say that I do some consulting, and I'm on a steering committee for one of the companies, Regeneron, that makes one of the antibodies that I'm going to talk about, linvoseltamab. And also, my wife's an employee of Johnson & Johnson, which makes daratumumab, teclistamab, one of the CAR Ts, and another bispecific antibody called talquetamab. Let's review what we've learned so far. Remember, amyloidosis is a plasma cell, AL amyloidosis, it's a plasma cell disorder. So you get an overgrowth of plasma cells in your bone marrow. That abnormal clone, in this case, I'm showing you a cartoon with a clone of lambda plasma cells. They make misfolded antibody proteins, misfolded light chains. These form fibrils that deposit in tissues, and in between there's a middle stage where you get these this clumping and these misfolded proteins still circulating in the blood, and these are also toxic to organs. And there's a lot of evidence that even these pre-fibril species can injure the kidneys or the heart. Okay, so this is sort of like the way amyloidosis affects our bodies and causes organ injury. And this is a general list of the therapies that are either available or in development for AL amyloidosis as of this year. And each column is a different class of medications. And we already heard about Dara-Cyborg-D from the Andromeda study, right? That's the one approved cocktail regimen that's available for newly diagnosed AL amyloidosis. And it's a perfect springboard because in that study, what they showed was that the addition of daratumumab, to a standard chemotherapy cocktail improved outcomes. And daratumumab is an example of an immune therapy. It's that far left column, the blue column. These are traditional antibodies. Traditional antibodies like daratumumab, and there's another one called isatuximab. These target the same surface protein on the amyloidosis plasma cells, CD38, and by doing that, they directly target the plasma cells, and they also have some secondary effects where they sort of help your immune system target the plasma cells too. A traditional antibody, if you look at the structure of it, think about it like a barbecue fork, right? You intuitively know what a barbecue fork does, right? You know what the business end is, and you know what the other end is, the handle, right? And so if you're trying to, if you're trying to move a steak on the grill safely, right? You poke it with the business end, and then the handle sticks up and it lets you grab it. With a traditional antibody, that handle is the way the immune system engages whatever the target is, okay? And that is part of the mechanism. And daratumumab and isatuximab, they actually have pretty similar activity in amyloidosis. They have pretty high response rates. I mean, we and others have published a series of patients treated with daratumumab after prior chemotherapy, and the response rates that have been reported are in the 60 to 85% range. So it can be very, very effective. And probably best use is exactly the way it was used in the Andromeda study, which is adding it to traditional therapy, because the side effects of traditional antibodies don't tend to overlap with the side effects of chemotherapy. So you can really, safely combine them. Elotuzumab is another antibody that targets something called SLAMF7 on plasma cells. Doesn't really have any real activity by itself, but it does combine with one of the other classes of medications called IMiDs, which includes Revlimid and Pomalyst, combines with those and enhances the effects of them a little bit. And then there are other antibodies. We just heard about anselamimab or CAL-101. That was the one that Dr. Cicero just showed us that induces, that provides some like cardiac benefits in patients with kappa light chain amyloidosis, right? Even though the target is novel, right? The target is the amyloid fibrils rather than the plasma cells, but it's still a traditional antibody. And there are other newer antibodies like Zamubafusp alpha, easier to call it ATO2, but this is something that also binds amyloid fibrils, but it targets something specific called GAGs on the fibrils, and those are present in all sorts of different types of amyloid, not just AL. So some of these antibodies that are in development may actually be useful for different types of amyloidosis besides AL. But again, these are all traditional antibodies. Let's talk about newer types of antibodies. That's kind of the meat of this talk. The first one is one that Dr. Cicero mentioned in passing. They have a study of it open, a drug called belantamab. I'm abbreviating it BELA or belamaf. This is what's called an antibody drug conjugate. So again, traditional antibody structure, the business end binds to something on the plasma cells called BCMA. Very good target for plasma cell diseases because it's very specific for plasma cells. So you don't get a lot of other organ or tissue toxicity because other tissues don't really have this target. So binds BCMA with both prongs of the business end, but then on the handle, there's actually a toxin attached to it. So you're not just using that handle to engage the immune system, you're actually delivering a toxin in a targeted way because of the way the front end binds the plasma cells. This toxin gets internalized and it is toxic to amyloid plasma cells. In multiple myeloma, the response rates to this antibody are about 30–35%, but in amyloidosis, it's about double that. And there are multiple series that show that. So it can be a useful therapy. One particular problem with it, though, again, this is a cartoon which shows that it binds plasma cells that have this marker BCMA, right? It binds to the plasma cells that have that marker, which is essentially all plasma cells at diagnosis. But one of the problems is that it has a very specific toxicity, which is eye toxicity. If you dose it the way it was originally developed every 3 weeks, about 3/4 of patients get pretty significant irritation of their eyes, and that can be associated with real visual symptoms that can take a long time to get better even after you've held the drug. Now, fortunately, this eye toxicity is dose dependent and also affected by the frequency that you give the antibody. So newer usage, newer development of this antibody involves spacing out the infusions. And I think this is actually going to be a helpful part of our, sort of armamentarium. But we just have to, I think, optimize how we use it. So it was approved and then taken off the market, and now it's approved again for multiple myeloma. And I think this is something that some amyloid patients could benefit from. Now, there's a newer type of antibody called a bispecific antibody, and there's 4 of them listed here. 3 are approved in myeloma. 1 is in development in myeloma and also for amyloidosis. Bispecific antibody means the 2 prongs of the antibody each bind something different. This engages the immune system in a completely different way. BCMA, it binds to the BCMA positive plasma cell on one end, but the other side binds to a protein called CD3, which is on immune cells. And when it binds the immune cells, it not only brings the immune cell right in proximity to the plasma cell, but it also activates that immune cell. So it's basically directing an immune attack on the plasma cells. And the response rates I'm going to show you are very, very different than what we expect with traditional antibodies. Now, something that's pretty exciting that's in development is tri-specific antibodies, where you can actually make it so that it not only engages the immune system like this, but it actually binds 2 different targets on immune cells. The advantage of that is sometimes the way myeloma or amyloid plasma cells get around these new bispecific antibodies is they shed the target, or they develop a mutation that makes it so they don't express the target anymore. And so if you don't have the target, the antibody can't bind. But if you add where am I here? Let's see. But if you make it so that the antibody can bind 2 different targets on the plasma cell, then it's sort of a safety net, even if it's no longer expressing that first BCMA. So this is called a tri-specific antibody. 2 markers on the plasma cell, 1 marker on the immune cells. And romantomig is an example of this, and this is actually being developed in myeloma and going to be studied in amyloidosis as well. So this is a super busy slide, and I just want you to focus on the columns in the middle that are in red, okay? These are all 4 different bispecific antibodies that bind BCMA and CD3. So this is 4 different companies, 4 different antibodies, but they all bind to the same target. They all have very similar mechanisms, right? And when you look at the first red column, VGPR plus, so very good partial responses or better, the percentage of patients that achieve a very good partial response or better across the board is pretty much 100%. And when you look at the rates of complete hematologic responses, it's in the 60 to 90%, even in some series, 100% complete responses. And importantly, these deep responses generally happen within a month. So very high response rates, very fast responses. And what the far right column shows us here is, or just mentions in passing, is that some of these complete responses are actually what we call MRD negative responses, which means when you use ultrasensitive tests to look for any evidence of residual amyloid plasma cells in the bone marrow, even when you look at 2 or 3 or 4 million cells, you don't see any cells in some of these cases. So these are super deep responses. There's also, by the way, a different bispecific antibody with a completely different target called talquetamab, has a different side effect profile because its target on the plasma cells isn't quite as specific for plasma cells, but it's also been studied in a handful of patients with AL amyloidosis, also very high response rates. So, bispecific antibodies as a platform have very high responses. BCMA is a great target, but there's going to be bispecifics with other targets besides BCMA too. And remember, this is how we think about response. Remember when we get a free light chain assay result in our labs. It gives us the kappas and the lambdas, and for each person, one or the other is the one that's your sort of bad acting light chain that forms amyloid. So what we're looking at is the difference between the bad light chain and the good light chain, and a very good partial response means you've reduced that difference to 4 milligrams per deciliter or less. So that's pretty, there's not much daylight between those when you get to a very good partial response. And we know that patients who achieve that kind of a response or better, a complete response, are more likely to have organ responses and more likely to have better survival down the road. Last thing I want to talk about is CAR T cells. I said I was going to just discuss this. This is cellular therapy. So the way CAR T cells work is we collect immune cells from your body just the same way as we would collect stem cells when we're doing a stem cell transplant. But in this case, we're not trying to collect stem cells. We're collecting immune cells from your blood with viral vectors in a lab. We modify the cells so that they express markers, receptors that target BCMA. What's on the surface of these cells is not BCMA, but it's really receptors that target BCMA. So it's the same target that bispecifics do. So instead of using an antibody to drag your immune cells in proximity of the plasma cells, we're actually just changing your immune cells so they can target the plasma cells all by themselves. And then we give those cells back to you and let them expand in your system and go to work. And there are actually 2 FDA-approved CAR T cells that target BCMA in multiple myeloma, and there are 3 other ones that are in pretty advanced stages of development. There's data about all of these in AL amyloidosis. The one we've heard the most about is called NXC201 or Nexicart. We first heard about it last summer at the American Society of Clinical Oncology meeting. At that time, 15 patients had been treated, and essentially all of them had had complete responses. Many of them had become MRD negative, and those MRD negative responses tended to occur within the first month. Last December, we got an update with 20 patients treated at that time. 19 out of 20 patients had responded. Of those patients, 16 of them had been tested for minimal residual disease negativity, and 14 of those 16 were MRD negative. This is a much higher rate of complete responses and also MRD negative responses, and much faster rate of responses than what we see with something like Dara-Cyborg-D. This company and all the companies that make the bispecifics that I mentioned before, they're all very, very eager to take these therapies head-to-head against Dara-Cyborg-D, because they think, all of them think their bispecifics or CAR Ts would beat Dara-Cyborg-D head-to-head. So there's a lot of excitement about these BCMA-targeted therapies. I'm a little bit out of time. I don't have time to really talk about the side effects of CAR T and bispecifics, but there are some very specific immune-mediated side effects. And for that reason, these therapies are generally given at centers of expertise that have experience giving bispecifics or CAR T. That's an important consideration to discuss. But the side effects, even though, again, they're specific, they happen at a predictable time point, and they are easily managed, actually, if you have experience managing them. Last thing, sort of as a segue to the next talk about novel immune therapies. Okay, this is what I just showed you about how traditional CAR Ts work. Here's a glimpse of the future. Okay, so in the future, instead of, we've already seen an early study of this, instead of taking out the immune cells, treating them with viral vectors to modify them and then give you back the cells, there's actually been a study, a very small study, but a study in Australia where they just gave patients those viral vectors, and those viral vectors modified their immune cells in their bodies without having to take them out. And then within a month or so, CAR T cells were detectable in the person's body without ever having to do laboratory manufacturing. And I think, it's highly likely that this is sort of the future of CAR T therapy. It's going to completely eliminate the need for the external manufacturing, and it's going to make these therapies much more readily and rapidly available for patients. And with that, I'm going to stop and turn it over to the next speaker, but thanks.
Thank you, Dr. Zonder. We see him a lot of the Portland meetings. He loves to come to the Pacific Northwest. So next, we have Madhav Dhodapkar. I'm not sure if I said that right.
It's pretty good.
Thank you. And he's going to be speaking on new generation immune therapies for amyloid.
Thank you, Rachel. Well, it's a pleasure to meet everyone. I'm new to Seattle, but not new to amyloid. What I was going to try and do is sort of piggyback on Jeff's talk. Jeff and I have known each other for 30 plus years. Try to sort of tell you a little bit about what's next in this field, some emerging insights, some things that we're doing here at the Seattle, at Fred Hutch, and sort of building a team here within the Fred Hutch. And I think being in Seattle, I should point out that this is really the key, because it's really a privilege as a physician and as a scientist for me to be able to meet you, because I think you guys are the inspiration for what we do. So really, I think we want this to be a dialogue as opposed to sort of me just giving you information. Amyloid is close to my heart. About 30 years ago, I was, and prior to that, during my days at the Mayo Clinic and early days of the so-called mass spec technologies, but I was involved in one of the first studies of a U.S. national cooperative group trial in light chain amyloid. Before that, we really didn't even think that we could do trials in AL amyloid. And this study was one of the first ones to actually show that if you actually reduce the light chains, you get organ function response. So this is something that was a fundamental change in how we approached this disease. Prior to that, we didn't really think this was feasible because we thought the damage was done. And that led us to create what we call organ response criteria. You heard about these cardiac CRs, renal CRs, et cetera, and that has sort of stayed on because that's now become the basis of how we treat amyloid. What I was going to try and do, I think you already heard some of the stuff, the concept that maximizing reduction in the precursors is the key to trying to reduce or improve outcome in amyloid patients. We heard about T-cell redirection therapies. The importance of CD38 as a target came out with the studies like Andromeda, right? That's what we learned, that this is a really important target that impacts amyloid patient outcomes. But there are lots of unmet needs. There are lots of opportunities. We can improve T-cell redirection. This whole concept of bispecifics and CAR T cells, we're in the early days. I'll tell you how. We need new targets. We heard about BCMA, we heard about CD38, but that's not enough to be able to sort of get at all the diversity of cancers that exist. If we really want to cure the disease, this is true for curing myeloma and true for curing amyloid. And we need to make this accessible to patients, to cheaper, easier, better, because otherwise it's just not broadly feasible. One of the things that I focused on, at least in the past year, is trying to build a team within the Fred Hutch, and now we actually have over 8 physicians who are involved in the care of plasma cell disorders, several of them with prior experience in treating patients with amyloid. Kara has been the leader in the context of taking care of amyloid patients. And we now have a whole range of research laboratories. And this is relevant because the field of CAR T cells, for example, was pioneered here. The field of in vivo CAR T cells was pioneered here. And we, of course, have several industry partners in biotechs that have sort of either been interacting or spun out of this institution. But I think some examples of areas we're working on include how to preserve T cells as we use T cell engagers, how to make T cells work specifically at residual cancer cells so that we can get to curative outcomes. And I'll tell you a little bit about developing new platforms, new kinds of T cell therapies, new targets, new ways to make CAR Ts. I obviously cannot discuss everything in this very, very short period of time. So I'll just give you a very, very quick flavor of stuff that we're working on here. I just want to emphasize the real important role of patients in this process, because everything we do, which is maybe 5 years away from entering the clinic at this point, actually depends on patients, because it is through an iterative process of collecting biospecimens during clinical research that we can actually develop the next generation of therapies. This is what happened with all the other therapies you saw. And those were only made feasible through this kind of iterative process. One of the hypotheses that we've come to appreciate now is that the reason why we don't cure myeloma or cure amyloid is because some cells survive. Not everything is killed off. And we're now beginning to develop new technologies to find those cells and find the markers that are not the same as on traditional plasma cells. And so then if we're able to actually target those cell types specifically that we call long-lived cells or persister cells, we think that that's going to be the key to develop curative approaches. And we have now the ability of specifically targeting T cells against those kinds of cells. Again, something currently in the preclinical setting. The other question is, can we find new targets against myeloma? I told you about CD38, right? It turns out that we can take advantage of other ways of recognizing the immune system. So immune systems in us sort of diverged about 500 million years ago when a different form of immune system existed. And we can take advantage of the older kind of immune system to find targets that we cannot see through the modern immune system methods, and then apply it back to developing new bispecifics and CAR Ts. And that's led to a discovery of a target called MM3 that we expect to bring to the clinic initially in myeloma, but then also in the setting of amyloid. Can we improve on CAR design? CARs, as you'll see on the left, is really what the CARs look like. But this is really a Model T, for those of you who remember the origins of automobiles. And of course, on the right is a future car that none of us currently have, but all of us want. But essentially, nature actually is far more sophisticated than the design of the car. And what we're appreciating now is that using AI and a few other approaches, that we can actually modify and improve protein design. And that has the potential of allowing us to create what we call chimeric T cell receptors. We've already sort of, some of the early work has already been done here at Seattle, at the Fred Hutch in this space. And the advantage of this approach is that we can now create multi-specific receptors against multiple targets. You just heard about how we can target some BCMA negative cells through a tri-specific antibody. What if we could do multiple things? What if we could make a CAR that's specific for, or a chimeric T cell that's specific for that one patient, based on what that patient's pattern is? And then we need to try to improve feasibility and cost and access. And this is something that Jeff just mentioned, that we can actually begin to make the CAR Ts directly in the body. And there are many approaches. You heard about the injecting viruses into the body in this setting. One of the things that we're sort of trying to figure out is, can we actually make the viruses better So we have to inject far fewer viruses. Can we take advantage of the technologies that were developed during the COVID vaccine, and then essentially make a CAR T production as simple as a COVID vaccine, and with a substantial reduction in cost. And there are several things that we're sort of currently working on, including an approach that involves what we call bedside manufacturing, where you would make it just like you go for your oil and lube change in a car, you can get your CAR T made in 2 hours. So I think those are the kind of things that are coming to the clinic, and they will actually be applicable to patients with amyloid as well. But I think the biggest issue is going to be with the reference to the cost and the risk of the toxicity that we want to reduce. The one other thing I'll just close with is this concept that we've recently discovered, which is that in our patients, particularly in both plasma cell in myeloma and amyloid, that the immune systems of our patients are actually older than their chronologic age. And aging could actually be a very important part of this whole process, because protein misfolding, which is at the heart of amyloid formation, is actually a feature of aging. And so if we can reverse that aging, then we could actually try to address some of the amyloid formation biology easily. And again, I think this is a process that requires the iterative conditions. So I'll leave you with this picture of the fountain of youth, which I think is really an important concept that we need to think about in the future. But there's a lot more exciting stuff now that we know the roadmap. Actually, that actually can apply to amyloid, both in the context of new targets, new platforms, and I didn't get to talk to you about this, but also new preclinical models to test new therapies with a goal of trying to improve organ function, particularly in patients who have significant ongoing organ damage.
Absolutely. But then that product goes to the liver for the first activation step. And whatever comes out of the liver is still not ready for prime time. So it has to go through the kidneys for the final step of activation. And the product that comes out of there is the final most active form of vitamin D that is involved in calcium and phosphorus metabolism in our body. And together with a hormone called parathyroid hormone, this axis helps our bones stay healthy. So as part of our management of folks who have kidney disease, we look into the vitamin D, calcium, phosphorus metabolism as well. And then while the kidneys do not produce red blood cells, but they produce this hormone called erythropoietin, or EPO for short. And that EPO hormone goes to the bone marrow, gives it the signal to produce red blood cells. So as kidney disease advances, there is less of that hormone production, so our folks become anemic. And so we frequently give this hormone as a subcutaneous injection to help get this bone marrow the signal to continue to produce red blood cells. And then, as we all know, kidneys help us make urine, and that's how we principally regulate water metabolism in our body. And any mineral that you can think of, sodium, potassium, chloride, bicarbonate, uric acid, calcium, phosphorus, magnesium, they are all regulated by the kidneys. So they are maintained in a balance in the body by the kidneys. And then blood pressure regulation in our body goes along several axes, of which kidneys are the major organ that regulates blood pressure through both control of water, fluid, salt in our body, as well as some neurohumoral axis that it works on. So it maintains the blood pressure in our body. And finally, next to last, every reaction in our body produces acid like proton ions, whether that's eating, respiration, any reaction. So our body cells metabolism cannot work if our blood pH is not maintained in very close numbers, like between 7.3 and 7.4. So the kidneys are the principal organs that get rid of all the excess protons that are produced into the urine and help maintain that pH balance so that all the chemical reactions and metabolism in our body continues unchecked. And finally, I intentionally left the last one, which I think you probably, if I had asked you from before I started telling you about what the kidneys do, that would have been the one you would have thought about. Well, kidneys are the major organs that help get rid of waste products from our body, and including toxins and other metabolites. So the reason I showed you all of these is because this last function of the kidneys is the way we objectively measure kidney function. All the rest of the things give us abnormalities in the blood and other cells, and we treat them, but figuring out how much blood the kidneys are filtering per unit time is the measure how we define kidney function. And we'll look at that as we move along. Okay, but before we go there, what is the kidney functioning unit? So if we take a kidney and slice it, you will see this structure. There is somewhat of a denser outer portion called cortex and a lighter inner portion called medulla. And in the inside is this weird worm-like tube called nephron. That is the main functional unit in the kidney. It comprises of a head, which is a filter, which is linked to this highly convoluted tubule, which makes a hairpin turn and then joins multiple of its neighbors through a collecting tube, at the end of which a micro urine droplet comes out. There are about 1 million of these structures in each kidney. Well, at least there are 1 million when we are born. We, of course, lose them as we age, but this is the main structure. Particularly germane to our understanding of amyloidosis is the filter part of the kidneys. So this filter, again, understand this is microscopic. There are 1 million of these in each kidney. So we're talking about a microscopic level here. So this filter is composed of a highly tightly wound up regulated blood vessels called capillaries, which have specially designed walls, which are a bit leaky. And this structure is housed in a highly developed filter or a cup. And together, this makes a filtration barrier. This filtration barrier has 3 layers, and it has certain size of pores to allow fluid and electrolytes to pass through. It also has a particular charge, so it will not let negatively charged proteins like albumin and other proteins to pass through. It will repel them back. So it is designed to keep big things like all kinds of blood cells, big proteins, everything back in the blood, while only let water, electrolytes, waste products to go through into the next part of the nephron, which is the long tube, where additional processing takes place. So the last diagram there is an actual biopsy slide of how this filter looks. So if you look at it, it is composed of all these channels. They are wide open, nicely lined by their boundaries. Their walls are nice and clean. There's open space both inside, and it's surrounded by a urinary space. So with this background, unfortunately, this is what happens in amyloidosis, where the amyloid fibrils deposit in a proteinaceous manner in these filter units and just destroy the normal architecture of these filters. And the normal barrier function is disturbed, and hence we start spilling a lot of protein from these filters through these tubes into the urine, and develop what we call as nephrotic syndrome. So this is what lies behind the pathologic lesion that happens in our kidney in amyloidosis. So what are some of the manifestations? You've seen most of these, and you've heard about this in the introductory talk that we had, but and not everybody gets all these symptoms. It can be a mix of variety of symptoms, but usually swelling, pallor, anemia, loss of appetite, nausea, all of those can come in, particularly swelling in the legs and other parts of the body, increased propensity to form clots, accumulation of fluid in the abdominal cavity and the lung cavities. So that can happen. People can have low blood pressures and dizziness, lightheadedness with it. And if we are to check the blood, we will see the creatinine might start going up. In the urine, there is a very high amount of protein, usually albumin protein. the cholesterol levels go up, serum albumin level drops, and if I'll take your urine and look it under the microscope, I might find a lot of same processes going on with a lot of so-called oval fat bodies or waxicats, which are nothing but accumulation of protein and fat in the urine. So we will see a constellation of these symptoms and signs and clinical lab aberrations in somebody with a nephrotic syndrome. So how do we measure kidney function, and how do we stage our kidney disease process? So there are two main ways of doing it. One is this measure in the blood called creatinine. Creatinine comes from our muscles. It is not produced by the kidneys. So the more muscular, bigger the person is, the higher will be their creatinine. The more petite, lighter frame person is, the lower will be their creatinine to begin with. This doesn't mean that one is good or one is bad. So normally the range is about 0.8 to 1.2. That's kind of like a normal range, although there could be a little bit of variation around it as well. So as the creatinine goes up, it means that the kidneys are not filtering blood very well. This creatinine molecule is so small that it is taken by the blood to the kidneys and freely filtered out into the urine. So we take this property of creatinine as a surrogate marker of how effectively the kidneys are filtering blood. So if the kidneys are not filtering blood well, they're not doing their job well, they will not be filtering out this creatinine so effectively, so it'll start building up in the blood. So our creatinine number will go up, which will mean less normal function. But just to understand that this creatinine itself is not toxic to the kidneys or the body, it's just a surrogate marker for us to understand how much the kidneys are working. However, a better way of understanding how the kidneys work is this second part. Please memorize this equation. No, I'm just kidding. So not even, don't know what it is. So the lab has this equation. So it's inbuilt in the computer system. Whenever you go give a sample and your creatinine is checked, this horrendous regression equation involves three variables only: your age, your gender, and the creatinine that is checked in the blood. So based on these three variables, this equation gives a number we call as glomerular filtration rate. E means estimated because it's an estimation. It is not 100% accurate, but close to that. And that's what we can practically do in a clinical setting. Otherwise, I'll have to take one of you to the nuclear medicine lab, start 2 IVs, give you infusions like every 30 minutes, check blood and urine all the time. So that's how we will get a extremely accurate determination of GFR. So we can't do that. So short of that, some brilliant investigators developed this equation that has gone through several iterations over the last 20 years. And this CKD-EPI 2021 is the most prevalent currently in use right now. So based on this equation, a normal GFR is about 120. What that means is our kidneys filter about 120 milliliters of blood per minute. In other words, about 150 liters of blood in a day. So, or at least this is what we should be doing when we are born. And we, again, don't do that. I probably don't have this at this point. So we all lose a little bit of function with time, but in general, this is what normal should look like. So based on this, what is abnormal? So we stage our kidney diseases not based on creatinine, but based on the GFR that we measure. So up until about 90, from 120 to 90, we don't worry about things. It's like, okay, it's okay, it's just normal, really not a big deal. From 90 to 60, we start thinking a little bit more carefully about things. We say, okay, you might have stage 2 kidney disease. Again, that is not that problematic. The issues start when we approach stage 3. Stage 3 is when our GFR drops up to about 60. And since our stage 3 is arbitrarily very long, anywhere from 60 down to 30, so we have bisected this stage into stage 3A and 3B, where a drop in GFR from 60 to 45 gives somebody a stage 3A designation, and from 45 to 30 as a stage 3B designation. Unfortunately, as the disease process goes on and we drop our GFR below 30, we enter stage 4. That becomes stage 5 at 15 or less. And usually, majority of the folks require dialysis when the GFR is a bit 10 or less. But that's a generalization. However, we don't have to wait till stage 5 or late stage 4 or when people develop symptoms to refer folks for transplantation evaluation. We can do that somewhere around about mid to late stage 4 when we see the GFR falling 20 or less. So this is how we measure kidney function and ascribe stage of kidney disease based on this GFR number. So the aims of therapy in AL amyloidosis, I'm just going to quickly summarize here and tell you where my role comes. So almost entirely all the way down up till this entire is Dr. Cicero's domain. So she will be giving you chemos and immune therapies and CAR T cells and bispecifics and trispecifics I just learned today myself. So all of those therapies are geared toward reducing the production of the light chains by removing the involved plasma cells, which in turn would slow down the new amyloid deposition in the tissues and hopefully lead to gradual regression of the existing amyloid deposits. And where I come in is sort of like a supportive role, where I will help with some of those manifestations of nephrotic syndrome that we looked at: swelling, edema, electrolyte problems, blood pressure issues. So I'm there to help together and discuss as a team with our hematology colleagues as to what would be the next best steps. So about 10, 12 years ago, Dr. Palladini came up with a very simple staging system for kidney disease involved in AL amyloidosis. He basically utilized two main measures. One was, what is the GFR at the time of diagnosis, and what is the amount of protein somebody is leaking at the time of diagnosis. So based on that, the patients can be categorized into 3 risk groups. Risk 1 has the best of outcomes because they have good kidney function at the outset. They have more than 50 mils per minute of GFR. They have minimal protein, less than 5. And then on the flip side, those folks who unfortunately come into stage 3, they have worst of the both worlds. Their GFR is low, less than 50 at diagnosis. They have more than 5 grams of protein. And then there's an in-between stage where they can have one or the other abnormal. And while one is normal, the other parameter may be abnormal. And looking at our folks, that is what constitutes actually 60 to 65% of our patients when we first see them. And the folks we find in stage 3 are usually the ones who unfortunately have been left undiagnosed for a long time, and they reach us quite late after diagnosis. So as the risks are projected there, the 2-year risk of reaching end-stage kidney disease status or requiring dialysis is pretty minimal for stage 1, particularly in this day and age of all the new therapies that have come up. And it's intermediate for stage 2, and it's still pretty significantly high for those with stage 3. Having said that, the thing to remember is that even in folks in the high-risk group, their ultimate prognosis will actually also depend on how robust is their hematologic response to the treatments that are being given. So with this scope, what do we do when our folks unfortunately do reach end-stage status or they require treatment? So of course, there's dialysis, and then I'll end this talk with a little blurb about transplantation. So dialysis is usually of two main types. One, it can be delivered in centers around, you might have heard of Northwest Kidney Centers, DaVita, Fresenius. Those are dialysis centers around the city and the country. Or it can be done at home as well. The vast majority of the patients do the blood dialysis or hemodialysis in centers. At home, we actually have the capability of doing a special kind of dialysis called peritoneal dialysis, where a catheter, we use sugar solutions and instill it into the abdominal cavity, and I'll talk about in just a minute. And we can also do the blood dialysis or home hemodialysis at home. So, and for several years now, and this is the prevalent status in our country, that the vast majority, 86+% of the folks do hemodialysis in centers 3 times a week. Each treatment is traditionally about for 4 hours. And about 12%, 12-15% of the patients are doing peritoneal dialysis with the sugar solutions at home. And a very small percentage, 2 to 3%, are actually doing the blood dialysis, hemodialysis by themselves at home. So in order for us to deliver hemodialysis or blood dialysis, we need to have a good, durable access where we can put needles and gain blood, both for cleaning and returning blood. So there our vascular surgeons help us. So there are 2 forms. One's called an arteriovenous fistula, which is shown here, where a surgeon will join your own, the patient's own artery and a vein together. The artery is in red, it's a high pressure chamber, and the vein in blue is a low pressure capacitance vessel. So the high pressure keeps pushing blood into the low capacitance vein, and over time that vein gradually gets bigger and more prominent to be able to accept needles successfully. This process of maturation usually takes about 3 months or so. However, in individuals and this is how, as it shows here, that once the vein becomes mature enough, then the needles can be placed in to gain access to the blood to the dialyzer machine and then returning back. But in individuals whose vasculature is not robust enough to create this arterial venous fistula, the surgeons usually put in a PTFE synthetic graft in between the 2 blood vessels, and over time, like a couple of months or so, the graft becomes strong enough that then it can take the needles instead of those being stuck into the vein itself. So how does the dialysis work? I don't know. I think, yeah. So the blood goes from the fistula or the graft through a help of a pump into this dialyzer. This dialyzer is composed of hollow fibrils with a semi-permeable membrane, and this is bathed by fresh dialysis solution being provided here. The fresh dialysis solution has all the electrolytes, sugar, glucose, other things in good concentrations. So the through mechanism of diffusion, osmosis, and convection, exchange happens. Bad stuff goes into this dialysate solution, good stuff goes into the blood. So the used dialysis solution containing urea, other electrolytes and stuff is removed, and the fresh blood, good blood, is then returned back into the patient. And this is hollow fibril, which is the main dialyzer that is used. It is an ingenious structure. You can look at this fibrils. It increases the surface area tremendously, and you can have a lot of exchange between blood and the dialysate for excellent cleaning that can take place. And not just that, the blood flows in one direction and the dialysate flows in the opposite direction, so there is never supersaturation. And so the process of exchange continues in a very nice manner. So this is, in essence, just a basic physiology of how blood dialysis runs. So just a couple of pictures. On the first picture up there is a prominent arteriovenous fistula, which is ready for use. In the lower picture, it is being cannulated through needles, and then a person getting dialysis in one of the centers. I spoke to you a little bit about that 2 to 3% of the patients do this process at home instead of going to centers. This is what a home hemodialysis machine looks like. It just needs a good water supply connection, and it comes with cartridges, and you're good to go. And it kind of is almost the size of one roller, and you can take it with you on the plane, except the only thing is that wherever you go, you might need either a good water source or some bags for dialysis. What about the second type of dialysis we talked about, peritoneal dialysis? So it involves putting in a silastic catheter in the belly, the tip of which goes all the way down into our pelvis, the most dependent area in our body. And then it is easily held through a tape, or some people like to wear it in a lanyard, or around, which is around their neck. So simply bags that contain good sugar, concentrated sugar solution with electrolytes is connected through silastic tubing to this catheter. The good solution is instilled, which bathes the abdominal cavity, usually a membrane called peritoneum, in which it goes. This peritoneum has all these blood vessels that form the basis of exchange between the fluid bathing them and the bad stuff that's in them. So the rough stuff goes out, good stuff goes back in, and then this dirty dialysate fluid, which waste products, is drained out. So this can be done either manually. Folks can hook themselves up, unhook themselves, leave it in the belly for a while. 4 hours later, they can hook themselves to a drainage bag, and by gravity, the fluid, the waste product goes out. Or the vast majority of folks use this machine called dialyzer, simply. It's called a dialyzer. It's usually it's done at nighttime for the most part, and the program is built in, and you just hang the sugar solutions on a pole, make a connection with this machine and with yourself, and then the dialyzer cycler will set up the frequency of solutions being instilled when they need to drain out. So we have anywhere from 3 to 4 to 5 cycles in the night, depending on how long the exchange is. So this is, in short, what peritoneal dialysis is. So we'll end by a blurb about transplantation. So according to the UNOS, which is the United Network for Organ Sharing, at least from the data from 2022, only 30 to 40 cases out of the total 22,000 kidney transplants that were performed that year were for all types of amyloidosis. And this is not just AL, it was all types of amyloidosis. So as you can imagine, a very, very small number of patients got transplant. And that kind of still remains the case. I'm talking about kidney transplantation, sorry. I should mention that. This is not stem cell transplantation. So, and I think the reason has been that some of the data is old and comes from pre-bortezomib and daratumumab and bispecific era, where drug toxicity was a big concern, relapse was a big concern, infectious complications was a big concern, patient mortality was a big concern. So the transplantation for patients with amyloid-related kidney failure has lagged behind, but it is getting better. In this slide, these are single center experiences from 3 large centers, Boston University, the UK, and the Mayo Clinic. And they had about 50 to 60 patients each. You can see at least 1/3 of the patients had cardiac involvement in these studies. And the American group had more patients with stem cell transplant. The British group had only 1/4 of their patients who had stem cell transplant. But the most significant thing is the 3rd and the 4th column, or the 4th and the 5th column, where you can see that the median overall survival exceeded 10 years. And at least Boston University gave their data on the survival of the kidney transplant. It lasted at least 8+ years. And the recurrence was exceedingly low. It was anywhere from 14 to 30%, and took anywhere from 5 to 10 years for having any recurrence of amyloid in the kidneys. And again, the message that's consistently comes out, both from Dr. Cicero and other colleagues, hematology colleagues, studies and their presentations, and what we found here was that those folks who went into either complete remission or had very good partial response had the best outcome. They had the least evidence of recurrence and best median overall survival. So based on these and emerging data, the UNOS has come up with this declaration, which is pretty amazing, that the outcomes of kidney transplantation in patients with amyloidosis now actually is almost the same as if someone got a kidney transplant because of diabetic kidney disease. Having said that, the overall survival and the kidney outcome still is not as robust as you would see in other kidney failure causes, but 8 to 10 years of median overall survival, similar amount of kidney graft survival is an amazing outcome. And I think this is all because of the deep hematologic responses we are now seeing with the wonderful armamentarium of medications which Dr. Cicero's group is coming up with, and that's helping our patients get to this. And so it's very reasonable now to offer kidney transplantation for carefully selected group of AL amyloidosis patients who are in hematologic complete remission or very good partial response with mild or moderate degree of heart involvement or less. But we still, of course, need more studies in this arena. So with that, I thank you for your attention.
Thank you. Welcome back, everybody. Thank you. We're going to do a little Q&A before we introduce Mary. So we have some questions, and is David Skurlick here somewhere? Okay. When we do our questions, we'd like to have everybody say your name and where you're from, because some people like to get acquainted with you if they live in close to you, and what type of organ you have in treatment. So can you do that? Is John here? Okay, we have to use the same mic. Okay. Your name and where you're from.
Okay, my name is David Skurnick. I'm from Kirkland, local here, and I have amyloidosis. What's that?
Organ.
Oh, and my organ involvement is heart, and right now I'm in.
Talk about nutrition, because you all need to know your nutrition. Oh, rescued. Thank you. Thank you. Okay.
Docs didn't all disappear.
All right. Well, hello, everybody. So I'm definitely seeing some familiar faces out here in the crowd, which is great. My name is Mary, and I'm one of the dietitians that works here at Fred Hutch. I primarily work with autologous transplant groups. I also work with the myeloma service, which is where you all are living if you've got amyloid. And I'm also the primary dietitian for myeloma patients on the CAR T-cell group. So if and when the CAR T-cells actually come up for amyloid, if you're getting it here, I will be the one that's seeing you. So that's great. And just so you know a little bit about me, I've been at Fred Hutch, well, previously SCCA, now Fred Hutch for about 17 years now. So been here for a while, have seen it done, and have seen the strategy, the treatments just become amazing for all of this. So today we're going to talk just a little bit about active treatment and what you can do nutritionally to get through that. I'm going to focus a little bit on GI amyloid because that's the one that tends to have the most nutrition side effects. So we'll talk about some strategies for what you can do with that. I'm going to touch on some common food and diet questions that I get, and then give you some recommended resources to look at as well. So I've done this a couple of years, and I always want to do this plug just so that you know who you're talking to. So nutrition and dietitian are not exactly the same thing. So anybody can call themselves a nutritionist. There's no protection to that term, so beware if you're talking to somebody who's a nutritionist, not a dietitian. They can't legally provide medical nutrition therapy. Nutritionists can't legally work in hospitals or clinics. A registered dietitian is somebody who's got a degree in nutrition. We've done an internship to get more in-depth clinical experience. We have to pass an exam, and then we have to maintain our education. So we are a legitimate health professional. In addition to that, there's something called a board certified specialist, which I am, and that means registered dietitian plus a couple of years of specialty experience in oncology and another exam that I have to pass every 5 years. So just so you know, I've been a CSO for 14 years of the time that I've been here. So active treatment. Really, the biggest thing when you're going through active treatment is I really want to make sure that you're focusing on maintaining your weight, because one of the biggest risks of all of these treatments is losing muscle. So this is not the time to be trying to lose weight. The goal really is to be holding yourself as steady as possible. Really making sure that you're getting enough fluids to support your kidneys, support your bowel health. So just making sure that you're staying as hydrated as possible. Fruits and veggies are great. They're so good for you. They can be a little hard to digest when you're going through active treatment. So I find that things like soups and smoothies are really good ways to get some of those fruits and veggies in and get that fiber in if you're not feeling so well and having a hard time. I also find that a lot of people tolerate animal-based proteins just a little bit better during active chemo. So things like eggs and yogurt and chicken can be a little bit easier to digest than things like beans and nuts. So it's one of those things that you just kind of have to watch and see how your body is responding to things. If you are struggling with any side effects from your treatment, please, please, please let your medical team know about that. If they know about things, they can absolutely help you with it. So please speak up. We don't want you suffering in silence with any of this. If your appetite's not great, the key is going to be maximizing the density of the calories that you're getting in. So this is where I'm going to want full fat versions of dairy if you can tolerate it, some extra nut butters, things like that. Small meals, kind of eating throughout the day, making sure that you're getting liquids with calories and protein. And I do want to say that all of these things that I'm talking about here, in the resources at the end of the talk, there's a link to the Fred Hutch website where we have all of our patient education materials available for you to look at. So if you go to patient education on Fred Hutch, you can look at all of our handouts. We have videos that talk about a lot of these different side effects. Taste changes, which is pretty common with some of these treatments. Focusing on, I find that people either go sweet or savory, and I can never predict which direction anyone's going to go. So we can work with both of those with healthy stuff. If you find something that tastes good, great. We're going to lean into that and find other stuff that works for you as well. Try something that you haven't had before. If you don't have a baseline for how something is going to taste, maybe it's okay now. Lots of sauces, lots of gravies, just keep everything soft and squishy. Like a plain piece of chicken may not taste great, but barbecue sauce or teriyaki sauce or something like that might help to make it more appealing. Constipation, we want to make sure you're getting enough fiber, but the right kind of fiber. Also want to make sure you're getting enough fluid. So too much fiber and not enough fluid can make constipation worse. If you need to use medications to help with constipation, again, talk to your doctors about that first, but there are definitely some that can help to get things moving along as well. On the flip side, diarrhea, soluble fiber. So this is the kind like bananas and oatmeal that tends to form a gel and kind of hold things together. Again, small meals, fluids with electrolytes. Small meals, you're going to hear for a lot of things because that works. Same thing with nausea. So small meals, cold food. Sometimes people get sensitive to smells, and cold foods aren't going to have near as much smell to them. Cooking smells can also be a little bit of a trigger. Ginger, I have really good luck with ginger and chemo nausea. If your mouth is really dry, doing saltwater rinses, again, lots of sauces and gravies, sour flavors. So just think about like if you have a lemon drop, that little zing that you get, that's your salivary glands kicking in. A little bit of coconut oil can help to loosen things up. So again, there's more information on all of this on the Fred Hutch website. Digging in a little bit specifically to the GI amyloid. So, and forgive me for any GI doctors who are in the group, but I just wanted to give you kind of a quick little overview of what happens with GI amyloid and why this is a problem. So those amyloid deposits that everybody's been talking about, depending on where they land in your gut, is going to affect what the different issues are. So if they get into the muscle layers, and if you're not aware of this, your entire digestive tract, that's basically one long tube of muscle. So if the amyloid gets into that muscle, it basically prevents it from doing the contractions that help to get food through your system. So it can just slow down how everything moves. If it gets into the nerves, and I heard somebody mention nerves here somewhere, if the amyloid gets into those nerves, basically those nerves can't fire to trigger that contraction, so that's also going to slow things down. If it gets into the lining of your gut, so all those cells that are responsible for absorption, that's going to slow down how much absorption you're going to be able to get, and it's going to mean some of that nutrition is just going to go straight through you. If it gets into your blood vessel walls, again, that's going to make them stiff and make them more prone to bleeding. So depending on where the amyloid lands, it's going to affect what your side effects are. Some specific things that you can do. So again, The mantra, smaller, more frequent meals. So if you have 5 or 6 more snacky size meals, that's going to be easier for your gut to have a chance to absorb rather than having one larger meal that's just going to likely go straight through you. Also spacing out your food and fluid intake. So if you drink a 16-ounce glass of water and then try to eat immediately afterward, you're going to be so full from that water that you're just not going to be able to get any calories in. So have a little bit to eat, have a little bit to drink, have a little bit to eat, and just kind of spread it out a little bit. Having your last meal of the day just a little bit earlier, so just kind of give your digestive system a chance to get stuff through the system before you actually lay down on it. So have the last meal earlier, sit upright a little bit, give gravity a chance to do its job. Again, with the liquids, if you're really struggling, liquid calories tend to empty out of your system and don't leave you quite as full and bloaty as solid food can. So things like soups and smoothies just tend to be a little bit easier for some people if you're really struggling. Fiber. Fiber's great, and you're hearing a lot about fiber on social media right now, so everybody's trying to fiber max. Fiber can be your friend or foe, depending on what your gut is doing. So if you're having diarrhea or constipation, too much fiber or the wrong kind of fiber can make both of those worse. So this is where you have to be a little bit targeted about specific things. And food sources of probiotics and prebiotics are really, really helpful. So probiotics are the actual bacteria. Prebiotics are a specific kind of fiber that those little good bacteria use as food. So having both of those can be really, really helpful. And there's a lot of really interesting research coming up on the microbiome. It's more targeted toward myeloma at this point, but there's some really early research that suggests having a diverse microbiome can help to slow down the progression of disease. So it's one of those can't hurt, might help with amyloid as well. So having some diversity can be really beneficial. And I'll talk a little bit more about that as well. And especially with the CAR T cells coming up, I'm very excited because there's also some suggestions that with CAR T cells and immune therapies that having a diverse microbiome can make those more effective as well. So we've got some really cool research in the process. If this stuff isn't enough, if you're still struggling with trying to do all of these things, a couple of other things. If you have access to a dietitian at wherever you're getting treatment, please reach out to them because this is what we specialize in, is tailoring all of these recommendations specifically for you. If you're not eating well, we may want to check some of your vitamin and mineral labs just to make sure that you're not deficient in anything. So that's something that we can do if we know about it. If you're taking a GLP-1, talk to your doctor about whether you might need to decrease the dose or whether you might need to hold it for a little bit while you're on active treatment. One of the side effects of those GLP-1s can be to slow your digestion. And if you're slowing your digestion and you're already struggling with amyloid, those two things can kind of pile on top of each other and make everything worse. So just, again, talk to your doctor about this one. You might end up needing nutrition supports. You might benefit from getting a feeding tube or IV nutrition if you're really, really struggling and just not able to do this on your own. This is not a bad thing. This is not a judgment on how you're able to do. This is just a tool that we have in our toolbox to help get some extra nutrition in you without you feeling like a foie gras goose that everybody's trying to force feed. So it's one of those things that we have as a backup. So please, we can do this. Anything that's really, really problematic. So if you're losing weight and continuing to lose weight, if you're dehydrated, if you're having any of that GI bleeding, if you have vomiting, persistent abdominal pain, please, 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 this is a medical emergency. Talk to your doctor about this as quickly as you can. We do not want you to get obstructed. That is a huge risk. So anything that's really, really bad or getting worse, please say something. Common questions that I get, and anybody who was here last year, this is kind of the same thing, and I've expanded on it a little bit as well. So special diets. You'll hear a lot about special diets for cancer treatment. So things like the keto diet, things like intermittent fasting, acid alkaline. There's really not a lot of good research on any of these diets, and most of the research that is out there is on very specific cancer types, or it's very specific, situations, or it's animal. So you're not a mouse. We can't necessarily translate what happens in mouse studies to what happens in human studies. Like keto in particular, that's been studied a little bit for a very specific kind of brain cancer. Doesn't mean that it's going to work for amyloid, doesn't mean that it's going to work for any other particular kind of cancer. And watch out for any diet or lifestyle program that wants you to spend a ton of money on supplements or any specific equipment or food. Just, if it sounds too good to be true, yeah, probably. What we generally recommend is kind of a Mediterranean-style diet, and that doesn't mean that you need to glug a bunch of olive oil and eat, leafy greens. The Mediterranean diet really is just plant forward, so 2/3 of your plate should be plant foods if you can handle that and digest it. So just looking for things that you like. Yeah, so plant-based diet, again, doesn't mean that you need to be vegetarian. It doesn't mean that you need to be vegan. Just looking for ways to add some plants in what you're already doing. So if you're making scrambled eggs, maybe throw some spinach and some mushrooms in, an extra piece of lettuce on your sandwich. Just any little bit is very helpful with all of this. Sugar. I hear a lot about sugar and cancer. We think that this got started with the PET scans that they do sometimes, where they give you that sugar solution that lights up and shows where cancer cells are. The reality is that every cell in your body needs sugar in order to function, and you cannot selectively deprive cancer cells of glucose. So the best analogy that I've ever heard is kind of thinking about, normally, cell division is, the cells divide and then they kind of go quiet, and then they divide and then they go quiet. They need a lot of sugar during that division stage, but then they settle down. Cancer cells are basically just dividing constantly, so they're just pulling a bunch of sugar out and using that. It's kind of the same thing as having a stuck accelerator on your car. So if your car's accelerator is stuck in drive, the way to fix that is not to run the car out of gas. It's to actually get it fixed. So the way to fix the sugar and cancer thing is having the amyloid treated, having the amyloid under control. That will decrease how much sugar that they're using. And you're going to make blood sugar for any food. Even if you were to cut out all carbs, all sugar from your diet, your body will still figure out how to make that glucose in order to function. The best way to think about this is just kind of balancing those carbs out with some fat and some protein, just to slow how quickly it goes into your bloodstream and raises your blood sugar. So if you're having a piece of fruit, maybe have some nuts, maybe have some cheese, just slow it down. Processed foods, another big one that we're starting to hear about a lot. The word processed and the words ultra-processed, there's not really a consistent definition on this yet. So people are making this out to mean different things. So the way to think about this. So processed basically just means anything that's been changed for convenience. So like bagged salad or milk or whole grain bread, something that's still recognizable, but has been altered a little bit to make it easier to eat. Ultra-processed, of course, everybody's thinking about chips and candies and things like that, but protein bars are also ultra-processed technically. Protein drinks are ultra-processed. Plant-based milk, meat substitute. So these things that you think about as healthy technically count as ultra-processed foods. The best way to be thinking about this is just looking at ingredient labels, choosing things with kind of shorter ingredient lists. Even ultra-processed foods are okay if they help you eat more real whole food and get more nutrition in them. So you don't have to be totally afraid of processed foods. Just make sure that you're being a little bit choosy about what you pick. Supplements. Really no good evidence that supplements can prevent or cure cancer. So again, be careful. If it's too good to be true, yeah. A lot of supplements can interact with medications and chemo. The FDA does not regulate dietary supplements. By law, they can't. So there is absolutely no guarantee that what something says on the bottle is what's actually in the product. And there are certain supplements that have been shown to actually interact with certain cancers and make them more of an issue. If there's something that you're interested in and want to try, talk to the doctors, talk to the pharmacists. We can help you decide what's safe. As a dietitian, I'm generally going to come down on the side of food instead of supplements. So putting this all together, especially if you're spending time on social media, nutrition recommendations seem like they change every single week. Real nutrition is not sexy. It's just really, really simple, and the basics are always going to apply. So just getting more plant foods in your diet is always going to be a good thing. There's really no one-size-fits-all approach for any of this. Your nutritional needs are going to be different, whether you're in active treatment, if you're in surveillance, if you're early stage, late stage, getting dialysis. All those nutrition guidelines are going to be different depending on where you are specifically. And yeah, again, if it sounds too good to be true, yeah. The best approach, consult with one of us just to get some personalized recommendations. And this is a quote that one of my coworkers came up with, and I love it enough that I've started putting it into all my slides. So, publicly available nutrition claims often exceed existing evidence. Stuff gets out there and becomes a thing before there's actually research to justify it. So please, please, please always be cautiously skeptical about anything that you see. The resources that I've got for you, so Cook for Your Life website. This one was originally developed by a cancer survivor who wanted to teach other people how to cook. The Fred Hutch Research and Integrative Medicine dietitians liked it and bought it and completely redid the whole website. So you can search by side effects, you can search by kind of foods you want. The Fred Hutch website, again, this is where all of our education materials are living, so they're free and open to the public. So if you're getting treatment somewhere else, you can absolutely get onto our website and look at our education materials. You can also go to the Academy of Nutrition and Dietetics and find a dietitian if you're in your area, if you're not close to where we are. And there we go. All right.
Thank you, Mary. Well, we hope that we can all prove her right when we come back next year, and we'll be healthier and eating more plant food.
Yeah, and especially knowing that the CAR T-cells and immunotherapy is coming up, I will have a lot more to say about that next year, because that's going to be great.
That's the importance of coming back every year. Thank you.
Do I need a referral to see you, like, or talk to you? Or?
Are you a Fred Hutch patient?
Yes.
Okay, just let your doctor know, or, okay, tell them and we can put in a referral. So just so you know, if you are a Fred Hutch patient, I don't bill insurance, so I am just available for you to see, so.
And please, since you have your folders, in the very back is an evaluation form, and please fill that out and return that to me or put it up here on the table. That's how we create our meetings, by what you say and what you think is important to have here. Thank you, Mary. And now we have Matthew Givens.
Yes.
Right?
That's me.
And he will be speaking on palliative care. So you'll see what the difference is. Here we go.
Good morning. My name is Matthew Givens, and I'm the medical director here at Fred Hutch for palliative care. I really appreciate the opportunity to speak with you today and just articulate a little bit more about what our clinic is and the services that we provide. I have no disclosures for this presentation. As I'm sure you're aware, we have a list of just agendas for things that I'd love to cover today, starting just with the complexity of amyloidosis, defining exactly what is palliative care, hopefully give you a sense of how we might be able to integrate into your care, and I'd love to close with a few patient stories and take questions at the end. So most of you, I'm sure, are experts in this matter already, but you understand that amyloidosis is a rare, serious illness that it can affect many organs in your body, and therefore it has many presentations and a whole host of different symptoms. We appreciate that sometimes prognosis can be poor, and that is often predicated on our inability to reverse organ dysfunction with our current therapies. But we don't forget that therapies themselves are also serious in terms of their risks and side effects, including both chemotherapy and transplantation. I think this is an excellent diagram that I pulled from the literature that just talks about all of the different organ systems that can be involved and how that translates into various symptoms that a patient might be experiencing. And then following this down, how those symptoms actually impact your daily activities, your social functionings, your emotional well-being, and just impacts of quality of life. So setting the stage, what exactly is palliative care? I will tell you, when you come and when I meet a patient for the first time, I like to say that we are that extra layer of support. Oftentimes patients come to me if there's a particular symptom that's been bothersome, if big medical decisions need to be made, or just how do I handle the stress of having a serious illness? The way I can be most effective is to get to know you better, identify those needs, and connect you in the right places. So you can see here, we work closely with your healthcare team That includes your medical oncologist, but also any of the other specialists you might be seeing across the center. We work to address the concerns that impact your quality of life, especially during treatment. And we also think of that in a holistic approach. It's not simply limited to the physical. We recognize that treatment has impacts both on emotional, spiritual, and social domains of life. And with the end goal of just how do we help you feel as well as possible? I'd love to take a minute just to clarify, because the biggest question I always get, palliative care, that's just hospice, right? And so I'd love to talk about the elephant in the room and distinguish what is palliative care and what is hospice care. First and foremost, palliative care is available at any stage of disease. We see patients from diagnosis all the way through end-of-life care. The big distinction is that hospice care is specialty end-of-life care, and thus a patient is only eligible when their expected prognosis is 6 months or less. I have patients that I follow for many years. If you have a diagnosis of amyloidosis, you are eligible to see palliative care. Additionally, we support patients during any form of treatment, including curative intent, whereas hospice care focuses primarily on maintaining comfort and minimizing life-prolonging treatments. And finally, as I've mentioned before, palliative care, we work collaboratively along with your other specialty providers to assess and prevent and relieve suffering. Whereas transitioning to hospice care, the hospice team really becomes your primary medical team and manages all of your care. So who are we? We are an interdisciplinary team that comprises both physicians, advanced practice providers, nurses, clinical social workers, pharmacists, and a spiritual care clinician. I just want to reiterate, we focused on specialized holistic medical care, looking at you as a total person and trying to tailor all of our therapies and interventions to support quality of life. And I want to drive home this final point. We are available from time of diagnosis throughout the life of the individual. Here at Fred Hutch, we have 2 physicians on our team. We also have 6 advanced practice providers. And we are fortunate that we have a dedicated palliative care pharmacist, dedicated palliative care spiritual clinician, and a dedicated palliative care social worker. So as I mentioned, one of the big reasons that patients come to my clinic is difficulty with symptom management. And I'm just here to tell you that we have a lot of tricks up our sleeve. And if something is bothering you, I would encourage you to seek help, because symptoms can have a drastic impact on how your day-to-day looks. With that said, it's not always just about the physical. So just remembering that social, emotional, and spiritual domains of life oftentimes are neglected here at a cancer center. And this is something that we would love to help support and address as able. It's not uncommon for people with serious illnesses to experience psychological and existential distress, or even stress in their family and support systems. Quality of life can be significantly impacted. Anxiety in particular affects people living with serious illness more than the general population. It's oftentimes due to fear, worry, or apprehension about what lies ahead. And we recognize that living with uncertainty can be very distressing. This is a great segue from my colleague, Mary. Here at Fred Hutch, palliative care is actually we are housed in the umbrella of supportive care services. So we work alongside your medical oncology teams, but we also have these great resources that we oftentimes refer to our patients, including nutrition, as well as physical medicine and rehab, integrative medicine, our social work, and psychiatry and psychology programs, as well as our child life specialists. It's not uncommon that when you come to one of us, you're going to see multiple. We recognize that communication and understanding is key to quality cancer care, and we try to support that. Sometimes it can be difficult to know who to call, especially if you have a lot of teams involved in your care. If you call palliative care and we believe that your question is better answered by another team, we'll try to get you to the right person to get that question answered. We also offer support for the family system, especially in navigating changes in illness and transitions in treatments. And finally, we can also assist you in completing advanced care planning documentations that communicate your preferences for your care should you become sick. We recommend that all adults, regardless of age or health status, complete a durable power of attorney for healthcare. Just simply a document that says who speaks for you in the event you are unable to speak for yourself. Before I became a palliative doctor here at Fred Hutch, I was an emergency medicine doctor. And I cannot tell you how many times patients wish they had completed this. I often saw people on the worst days of their life. And so please, if you take nothing else from this talk, please just think about who is that person who knows you the best, who can make decisions in the event you experience a medical emergency. We really want to empower you and support your choices because we recognize that treatments only work if they work for you. So we encourage you to talk to your doctors about what matters most to you and make sure that you can get the care that's right for you. I would just like to share a couple of patient stories and quotes to help illustrate how palliative care works alongside your healthcare team to help provide the best care possible. So John was a patient that had ongoing nausea and vomiting that had not responded to multiple medications. When he was referred to palliative care for the assistance with symptom management, he had been reporting that he was having daily bowel movements, but after further exploration, it was discovered that they were very small and that he never completely emptied after a bowel movement. We reviewed his latest CT scans, which actually demonstrated a significant burden of stool. The palliative care team worked with him to optimize his bowel regimen to where he had a full clean out and was able to keep things moving. His nausea and vomiting completely resolved, and he realized that he actually had to stay on top of his bowel regimen to mitigate that symptom. A few patient quotes that I'd love to share that were provided by a few of my colleagues. But one of our patients said, "People often tell me that they have a hard time believing that I'm as ill as I am. I tell them that the care I'm receiving makes the difference. After almost 2 years with palliative care, I feel like they know what is important to me and they do a great job of helping me achieve my goals." Another patient remarked, "For me, a lot of it is pain management, but that's far from all they do. They address my psychological as well as my physical needs in a variety of ways. I could not be more grateful for this outstanding group of people." And finally, "I've gotten my life back now that my pain is controlled. Thank you for your compassionate and pragmatic support." And the quote that I hear most often that breaks my heart, "I wish I had seen you earlier." So knowing this, I encourage you, please ask for palliative care. At any stage of disease of serious illness, we are here to help. We can tailor our interventions and our interactions based off of where you are in your trajectory. It might look different at different stages, but it's never too early to start the conversation. And with that, I'm happy to take any questions.
Thank you. Give it a try. It might be helpful. Now is time for Q&A. So, Mary and Matthew, John's treatment that will soon be spoken about from 12:30 to 12:50. Please be sure that you have the gray folder for ATTR. If you don't, the gray folder is out there on the table. Please be sure that you have the blue book. The blue book tells you everything you need to know about amyloidosis. And in the back, there are references for our websites. And please go to the website for amyloidosis support groups because it will give you, when the meetings are around the United States, it will give you doctors and treatments and centers of excellence to go to. It's loaded with information, so be sure you have this book. And if you're going to any doctors that don't know amyloidosis, you can give them one of these books and educate them, because that's what I've been doing for 24 years since I have had AL amyloidosis. So please get your blue books if you don't have them, and they're on the table out there.
Okay. Just want to remind you of some of the stuff that's available on the website here. So if you haven't been there, there's a wealth of information. There's some of our past webinars. You can see some of the stuff that's been recorded, access to all the meetings, shows some of that. The treatment sheets that you'll see in your folders perhaps, they're also available right there on the bottom so you can download them. This is, again, some of the Facebook groups that are there, so you can get in there with your peers. They're private, so you register, we validate you, so you're in really, truly with a group of your peers. You can also download the book in several languages. So that blue book that you have, you also have access to that there as well. And this video, good training video. So if your doctor doesn't know what amyloidosis is, they can watch the cartoon here and become experts. So, all right, I bragged to some of you about what I've been up to, so I wanted to close the loop with you. This is a picture of me, and I'm going to give you some hints, and I want you to see if you can guess where I sailed to this a couple of weeks ago. That's your first hint. Does anybody know what that is? It's a bird. Very good. Yeah. Get this gentleman a cookie. No, not Mexico. Well, yes and no. Yes, it's a blue-footed booby. It's not Mexico. Now we're getting closer.
Look at the color of the feet.
Yep. So this is a penguin. Come on, somebody. Yes. So I sailed to the Galapagos this year. It was wonderful. And I was telling somebody about it, and somebody asked me, why would you sail to the Galapagos? And another amyloidosis patient immediately said, because he can. And so that's why I do that. So because I feel compelled to bring more pictures, I'm sailing from Iceland to the Faroe Islands to Shetland this summer. So I'll bring more pictures for you guys next year so you can take a look at those. Okay?
So that's a blue-footed booby. See the blue feet?
Blue feet. Yeah. So do we want to do any other introductions or anything, or move right over to Dr. Aris?
I think we're ready to go.
Okay. It's all you, doctor. And you got it.
Thank you, John. Appreciate it. You're about my height, so people should be able to hear me if I leave it here, right? So thank you for the introduction, and thank you for the invitation again to Richard and Kara I did this last year too, and it's really exciting to be here. My name is Aris. I'm one of the cardiologists at the University of Washington. I'm a heart failure and transplant cardiologist there. I've been there as faculty for the past couple of years. I was born in Greece. Comes with a thick accent, so if you guys don't understand what I'm saying, feel free to pull it in the sort of evaluation you're doing at the end. It's good to be here, and I think this is a really important sort of event for people. It's a challenging disease to deal with, and I'm sure all this stuff helps a lot. So over the next 20 minutes, I'll try to take you through cardiac symptoms and treatments for AL and ATTR amyloid, hopefully in a way that makes sense and helps you negotiate this condition a little bit better, okay? I have no disclosures about these conditions. I'm sure you've seen slides like this before, but just briefly, why and how does cardiac amyloid happen? So AL and ATTR, so light chain and transthyretin amyloid, together constitute about 95% of the cases of cardiac amyloidosis. And we're increasingly recognizing both, TTR more so than AL, to be common conditions. Light chain amyloid occurs when abnormal plasma cells, which are types of white blood cells, form light chains that eventually misfold into amyloid fibrils. One thing I should mention is I was also tasked with waking you up after lunch, so I'm going to start moving my arms quite a bit here. Okay. In TTR amyloid, the abnormally folded protein is transthyretin, and it's a protein that's made in your liver and in your brain, and it's supposed to help transport vitamin A as well as TSH or thyroid hormone around the body. So cardiac amyloid occurs when these fibers deposit in various tissues on the heart, and they can pretty much deposit everywhere. They certainly deposit between the heart muscle cells, but they can go to the electrical system, they can go on the valves, pretty much everywhere. And depending on where they deposit, they can cause dysfunction. Now, because they deposit diffusely around the heart, one of the things that they can certainly do is cause very diffuse symptoms. So if I can use the pointer here, cardiac amyloidosis can cause heart failure, which is pump abnormality of the heart. It can cause arrhythmias or rhythm issues and conduction system disease, which is slow heartbeats. It can cause valve disease. And then it can cause autonomic dysfunction, which is involving the autonomic nervous system and how it impacts the cardiovascular system. We'll talk a little bit about this. And various other symptoms under other, such as fatigue, depression, insomnia, loss of muscle mass, etc. And that's just the things it can do in the heart. Many of you may know people or deal personally with extracardiac symptoms of amyloidosis because, of course, it's a systemic disease. So it can affect your gastrointestinal tract and your kidneys and so on and so forth. Heart failure is fundamentally a pump abnormality of the heart. So when the heart pumps ineffectively, various symptoms may arise that are primarily related to one of two things. Number one, fluid overload, or what we call congestion, okay? Things like swelling, abdominal distension, leg swelling, inability to breathe well when you're laying flat. And number two, symptoms of what we call low output, meaning the pump is just not sending enough blood to the rest of the body. And those can be symptoms such as fatigue or lightheadedness or nausea, weight loss, and so on and so forth. Both are very important, and both can have a profound effect on people's quality of life. Turns out heart failure and cardiac amyloid tends to act somewhat differently than garden variety heart failure. And trust me, these curves have been haunting me since medical school. We're talking 2010 here, okay? So forget about those. The way I try to frame amyloid heart disease and heart failure to my patients, and I don't know how good of a metaphor it is imagine the normal heart like a shiny sort of new balloon, the blue balloon in this case. It's compliant, it sort of fills well, and then it recoils nicely, it's elastic, it just works, okay? In typical heart failure, let's say because of blockages or whatever, what ends up happening is, well, you usually have a pretty easy time filling the balloon, but its elasticity, its contractile function goes down. Now, in all types of cardiac amyloid, the heart tends to behave more or less like the World Cup soccer ball, okay? So it's thicker, it's much stiffer, which is probably the key issue. So it's difficult to inflate it or fill it up with blood at higher volume that it would tolerate. And moreover, it really doesn't behave well when you underfill it. It tends to have a very narrow window of volume status that the heart tolerates before symptoms ensue. So a little bit more about that, especially as it ties to volume management and diuretics, okay? This is the mainstay of therapy when it comes to heart failure and cardiac amyloid, i.e. volume management and water pills, things like torsemide, furosemide, Bumex. Many of you may be on those medicines. And as I mentioned, the window of optimal volume status in cardiac amyloid heart failure is very narrow, okay? If you push too hard, patients become dizzy, they become lightheaded, their blood pressure is too low. On the other hand, if there's too much lassitude and you allow a lot of fluid to accumulate, people become congested, they have swelling, and so on and so forth, which can be difficult to manage. One thing I should mention is that very often in amyloid, even though you can have left-sided congestion symptoms, left-sided referring to the left side of the heart, meaning shortness of breath, especially when you lay flat at night, it's very common, more common than in other types of heart failure, to have right-sided congestion symptoms, which refers to sort of like congesting your venous system, your liver, your gut, legs, and so on and so forth. So we generally try to use diuretics, especially bioavailable diuretics are more often used, things like torsemide as opposed to furosemide, although both can be effective. And nowadays there's actually proprietary intravenous diuretics that can be used subcutaneously. And we combine them often with other medicines like SGLT2 inhibitors, like empagliflozin or Jardiance, dapagliflozin or Farxiga, as well as MRAs, spironolactone, and other medicines or such that all achieve pretty much the same thing. They help us manage volume, okay? A key part of this is, of course, and many of you will have heard about this, regulating one's sodium or salt and fluid intake too. More often than not, reducing one's sodium intake. Now, beyond volume management, standard heart failure medicines we're prescribing to patients with non-amyloid heart failure aren't that clear in terms of their response in amyloid cardiomyopathy, okay? Unlike in garden variety heart failure, there's no prospective large clinical trials in cardiac amyloid patients for pump function medicines. Now, I'm not talking about disease-modifying therapies for TTR and AL, such as, tafamidis, acoramidis, on the TTR side, or Cyborg-D and chemotherapy on the AL side, okay? These are just pure pump function medicines that are non-specific to amyloidosis. So in non-amyloid heart failure, we always talk about the 4 pillars of medical therapy. Many of you may have heard about those. But the 4 pillars don't exactly apply so well to cardiac amyloid. Specifically, vasodilators, such as losartan, lisinopril, valsartan, Entresto, things like that, are more tricky to use in heart failure. They can be used, but they often have to be decreased in dose or discontinued, precisely because the stiff heart is not able to keep up when we lower people's blood pressure down. Normally, when we bring people's blood pressure down, the normal heart is able to pick up and squeeze more and use its elasticity to move more blood and keep up with that lower blood pressure. But in cardiac amyloid, we have something called ventricular or heart vascular vessel uncoupling, and we're unable to maintain that balance, okay? Patients often have to decrease or even discontinue vasodilator medicines when they have cardiac amyloid. Beta blockers, which are the cornerstone of therapy in non-amyloid related heart failure, can also be difficult to use sometimes in amyloid cardiomyopathy. The principle is that basically the amyloid heart, which is smaller and stiffer, needs to complete many cycles, many RPMs to keep the flow going. And if you decrease the heart rate and so on and so forth, which can happen with beta blockers, and especially if you use a beta blocker that is also a vasodilator, because some are, you may run into the same situation where you have low cardiac output, low blood pressure, feeling dizzy, unable to sort of stand up without feeling lightheaded and unsteady, okay? They can be used, especially in patients who have a low RAF. It's worth a shot. But generally speaking, in my practice, if I run into side effects with these medicines, I'm quick to peel them off. 2 of the 4 pillars that can potentially be used in amyloid cardiomyopathy and have some retrospective data for them or observational data are SGLT2 inhibitors like empagliflozin, dapagliflozin, Jardiance, and Farxiga. I'm sure Richard's getting very upset with me for using brand names, but and MRAs like spironolactone or Plerinone and so on and so forth. These have the most consistent results, and part of it is probably because they really help regulate volume. They just help us use less Lasix and less Bumex and less of this and that. They block the kidney from holding on to volume at various different spots and allow us to keep patients dry. But as I mentioned before, hopefully not too dry, okay? An additional benefit of MRAs is that they hold on to potassium, which can be a challenge when you use high doses of loop diuretics. What about really advanced therapies like heart transplant? Amyloid often tends to have multi-system involvement, okay, by definition, and it often always manifests in older patients. It's much more common, especially TTR, after age 60, let's say. But for a small portion of relatively younger patients who have limited involvement or outside the heart, or who have extremely durable and strong responses to chemotherapy when it comes to AL amyloid, a heart transplant can sometimes be successful, and it can have a very good outcome. I will say for all advanced heart failure cases, palliative care consultation should be considered at minimum to help guide patients through what is sort of very difficult disease, which can be advanced amyloid. Now, enough about the pump side of things. We said that it kind of can affect the heart in a very diffuse way. What about the valves? So Aortic stenosis is probably the more pertinent valve condition in amyloid, especially TTR amyloid. It involves narrowing of the aortic valve, which is the last valve before the blood exits the heart. And just to give you an idea of how big sort of the scope of the problem is, 1 out of 6 patients, so about 15% of patients, who is referred to get a TAVR, which is a percutaneous groin procedure to replace the aortic valve. Back in the day, it just used to be done surgically. Now it can be done through catheters, which is amazing in and of itself. 1 out of 6 patients will have some amyloid-related cardiomyopathy and valve disease. And there used to be some hesitancy about as to whether or not this will improve outcomes in these patients, but it has become clear from retrospective data that transcatheter aortic valve replacement is effective and works is possible and works in patients who have aortic stenosis in the context of heart amyloid. Okay. One thing I should mention that I'm increasingly recognizing is severe aortic stenosis can be kind of tricky to diagnose in patients with amyloid because, fundamentally what you're looking at is whether the aortic valve opens or not, okay? But in patients with amyloid, the aortic valve may not really open that well because the cardiac output is actually kind of low. And it poses sort of like a diagnostic challenge that unless you sort of like suspect, might be a little bit difficult to diagnose. I would say most people look for it nowadays. Briefly touching on rhythm abnormalities with cardiac amyloid, by far the most common arrhythmia is atrial fibrillation in this group of patients. It involves about 50 to 75% of patients at some point with AL or ATTR amyloid because the atria, the top chambers of the heart, become sort of like enlarged and scarred and so on and so forth because of the stiffness of the heart, okay? And the symptoms may involve palpitations, fatigue, dyspnea, or worsening exertional tolerance. Historically, there's been a little bit of a debate on whether or not what we call rate control, which just means patients with atrial fibrillation, just slow them down, is good enough globally in atrial fibrillation and certainly within amyloid, because people have recognized that rhythm control, which is, hey, we got to get people out of AFib and keep them out of AFib, is more difficult to achieve in amyloid cardiomyopathy. And this is, it's pretty intuitive. The atria just blow up, have too much scar. It's more difficult to maintain sinus rhythm, okay? However, between this year and last year, for example, there's been a couple of papers that show that atrial fibrillation ablation, I should mention observational papers, not randomized trials, that AFib ablation may have some merit, especially in earlier stages of amyloid cardiomyopathy, where the likelihood of sticking with sinus rhythm might be better, okay? Alternative, you can use rate control, just slow people's heart rate down just enough, and or medicines like amiodarone or dofetilide to keep people out of AFib or at least rate controlled. And one thing that's key is, that's really not a symptom, it's a medical event or a sign. The risk of stroke in patients who have AFib and amyloid cardiomyopathy is very high. The atria don't squeeze well, even when in sinus rhythm, and the likelihood of forming a clot in the top chambers of the heart is high. So people should be, when they have AFib and amyloid, on anticoagulation and blood thinners unless there's a contraindication. Speaking about conduction system disease, if amyloid goes into your electrical wiring of the heart, it can damage it. And then instead of having AFib, you have this really slow heart rate, which means that oftentimes patients with cardiac amyloid need a pacemaker. We have recognized that with time, with this disease, patients who have pacemakers may need increasingly more frequent pacing from 5% to 10%, 20%, 40% or more. And that can have detrimental effects on the heart. But there's a solution for it, which is to consider more physiologic forms of pacing like cardiac resynchronization therapy or conduction system pacing that can sometimes help patients who have high pacing percentage that's adversely impacting their heart pump function. Ventricular arrhythmias are arrhythmias that come from the bottom chambers of the heart, unlike AFib. And they can be serious, they certainly can be life-threatening. One thing that's become pretty clear in the amyloid space is that unlike other forms of cardiomyopathy, other forms of heart failure, the risk of sudden arrhythmic death seems to be proportionately lower. In other words, it's more likely for patients to run into trouble and or die from a pump abnormality rather than an electrical, very fast rhythm that would respond to a defibrillator. So the benefit of defibrillators, especially for primary prevention in this population, is less clear than with garden variety heart failure, and it's certainly worth a careful discussion with your physician. Moving on to autonomic dysfunction, and I'll try to get through this a little bit more quickly. The autonomic nervous system, and you'll have a talk from Dr. Distad later too, is sort of like the silent, dependable, worker of your nervous system. It never takes a vacation. It works 24/7. It regulates things like blood pressure and sweating and so on and so forth. And much like the rest of the nervous system, people often have neuropathy and numbness in their feet, burning, tingling, and so on and so forth. The autonomic nervous system can also be affected, can become very dysfunctional in the same way that amyloid fibers deposit in the heart. They deposit there too. It's certainly more common for that to happen with certain forms of amyloid, like hereditary TTR amyloid as opposed to wild type, for example. But it can happen with any type. And it tends to manifest more early in the disease course than, let's say, for example, diabetic neuropathy. It just happens a little bit quicker. And the main cardiac symptom that I think stands out from an autonomic dysfunction standpoint is lightheadedness, especially postural lightheadedness, sort of like difficulty with maintaining one's blood pressure when they get from the sitting position into the standing position, or from the laying position into the sitting position, and so on and so forth. Because normally your autonomic nervous system is supposed to tell your vessels, hey, time to tighten up and sort of like keep the blood pressure going to reach our brain, okay? So people may stand up and feel very dizzy, okay, and that ties in nicely to sort of the intolerance to the vasodilator medicine we spoke about before, and or sort of like need a minute to equilibrate before they can keep going. And that's just your brain telling you, hey, we need to like hold up a little bit because we need more blood flow. Managing that is also something that can be challenging. It can be effectively managed with many non-medication related treatments, such as compression stockings. I'm sure many of you have tried those. They're not super comfortable, but they can be effective, as well as abdominal binders, which is essentially a compression stocking for your midsection, and those are really often quite uncomfortable. But other things like smaller, frequent meals to prevent blood pooling into your gut and sort of gastrointestinal systems, and preventing volume depletion by cautiously adjusting your volume intake and your salt intake, emphasis on cautiously, or preventing things that really deplete you from a fluid standpoint, like coffee or alcohol and so on and so forth. And of course, making slow and careful position changes when sitting up and standing is key. From a medication standpoint, some disease-modifying therapies can help with all forms of neuropathy, especially hereditary amyloid. You might need to get your diuretics, water pills, and your vasodilators adjusted down. And there are medicines that can help retain salt and fluid and also increase the blood pressure, which, especially coming out of the mouth of a heart failure cardiologist, sounds like a sin, but that may be what a minority of patients need in order to maintain a viable blood pressure. Emphasis on with caution in these cases. Lastly, I wanted to briefly talk about frailty and related conditions. So frailty is a complicated thing. Historically, the definition used to be centered around sort of like physical strength and sort of like rigor, things like muscle mass and grip strength and so on and so forth, so-called get up and go test, how fast can you get up from a chair and sort of like get going. But it's developed and evolved into a more holistic definition that basically describes the body's inability to deal with stressors. And that's very multifaceted in addition to physical weakness and loss of muscle mass and so on and so forth, unintentional weight loss, it involves many other things like depression, anxiety, isolation in many cases, malnutrition, fatigue, cognitive impairment, and so on and so forth. And it's really important to recognize because it results in lower quality of life and certainly has a much higher risk of poor outcome, even from a hard outcome standpoint, cardiovascular outcomes. So for example, in this paper, they showed that frailty is, as a syndrome, very common in patients with cardiac amyloidosis. Maybe half of patients may have it. And depending on how frail one is, your prognosis may vary vastly. So for example, patients that are very not frail, patients who are independent for their activities of daily living, and they're basically kind of moseying around and doing normal things, have a very low mortality at 1 year. But on the other side of the spectrum, patients who are dependent for ADLs, activities of daily living, things like sort of like getting dressed and so on and so forth, have a high mortality. And that's really important to recognize and focus in these cases. I think as physicians and as healthcare teams, we do a decent job at putting patients on the right medicines. It's been a long time since I saw a patient who was referred to me for TTR amyloid, let's say, for example, who hadn't already started the process for tafamidis or something like that. But what's really challenging for both providers and patients and their families is like finding, the correct balance of multidisciplinary care that you need that involves physical therapy and cognitive behavioral therapy, occupational therapy, and so on and so forth to help somebody holistically. And that happens because it's just a challenge. It's a financial challenge and a logistical challenge within the constraints of the system that we live in. There's no easy fix other than sort of like building up programs that happen at big institutions such as the Hutch and UW. And it's much more difficult in perhaps more rural areas and so on and so forth. But I really think I should emphasize that because I should acknowledge how difficult it is for patients and families to do that. And I think we need to do a lot of work in this field. So in conclusion, patients with amyloid have a broad range of cardiac symptoms due to amyloid deposition in the heart. Cardiovascular management can improve the quantity and quality of life. Heart failure behaves differently in amyloid than it behaves in non-amyloid heart failure. And probably the most central piece is managing volume and probably atrial fibrillation. Aortic stenosis can be dealt with. It is common. AFib, you should be on blood thinners unless it's contraindicated. And in newer studies, there's some data suggesting that rhythm control might be helpful. Pacemakers may be needed. The benefit of primary prevention defibrillators is less clear. Postural low blood pressure, orthostatic hypotension is common, and it should be managed with medication optimization and some non-medication strategies. And then managing frailty requires multidisciplinary collaboration and is central to the care of the patient with cardiac amyloid. So thank you so much, and I'm opening it up to questions.
Yeah, thank you, Dr. Aris. Okay.
Caregivers or supporters. All right, great. First of all, I would say that you've already heard a lot from Dr. Cheng about what's going on and from others too today. And the first thing is really to take a deep breath because, just 10 years ago, the whole conversation was very different. These meetings were truly support meetings that had nothing else to offer besides support. But now it's very different. Now you have a lot of treatments. You have a lot of things that can happen. It actually used to be a light chain amyloidosis meeting only. Like very, very few TTR patients were identified and very few therapies were even identified then. Now we have multiple therapies approved. And as you'll see, and this is meant to give you just a flavor of the future, there are lots of other therapies that are coming out. There is one challenge though, is that it's not easy, but it's always easier to find the first few therapies. But how to maximize from there to an optimal therapy is where the difficulty is. So if you're a patient of mine or of Dr. Cheng's or any of the other doctors who spoke today, if you've spoken ever to me, I always say, if I were you, I would do any trial that speaks to you. The reason is not because we want to actually put out papers or stand on podiums and speak about it. If we didn't do trials before, tafamidis would not be available to any of you. That's one. The second thing is that in a lot of these trials, we actually fight for patients so that you get slightly higher chance of being on the drug than on being on placebo. But also, there is still a lot of unmet need in this disease, and there's no one better than you all to know that there is unmet need. And to push this forward, you need to do a lot more work, because the jump from no treatment to treatment, even though it's so important, it's actually usually not as difficult as to go from having a treatment to an optimal treatment, because then you want to address more stuff. And that's also a message for some of the people who participate in our trials that don't translate to an approved drug later on, not to be disappointed, because this can happen sometimes. Those are my disclosures. They're really not relevant to today's talk. So the first one, already Dr. Cheng addressed, which is CardioTransform. We've had many patients. We still do have patients in this trial at OHSU. And this trial is testing a strategy of another medication that is already approved by the FDA called eplontersen. It's once a month injection. You self-inject it. And so yourself or your caregiver can inject it as well. And it reduces the amount of transthyretin coming out from the liver. Now, you might say, well, how many ways you guys want to reduce transthyretin from the liver? There are already other drugs approved. And that's a good question. But the point being is that we reduce transthyretin from the liver through different mechanisms. So even though we group them all as silencers, each one of them actually works differently. It's all chemistry. That's why no one wants to talk about it. And even physicians don't want to talk about it because they don't understand it well. But eplontersen, even though the net final pathway can be similar to vutrisiran, which maybe some of you are on already, it actually is a completely different drug. Not even from the same class, not even related in any way, shape, or form. That's why we test different drugs, because they're not what we call me too drugs. They're actually a whole different entity. And so this trial should be reporting in the next 3-4 months. What we're looking at from this trial is something new. Can we show that we can improve patients' feelings, function, less heart failure, less progression of the disease compared to what we already know? So the base case is that we get a 4th medication approved in the United States. That's the base case. An optimal case is that we show that by combining medications or by using this new drug, we actually might achieve better outcomes than we thought. That's why we supported this trial big time, and we enrolled a lot in it as well. Now, a different way of crushing that TTR that's coming out of your liver, that bad protein that wants to go to the heart and do stuff. Another way of targeting that is by doing something called gene editing. It's a permanent approach, as far as we know. So far, we have data out to 3 years, which confirms it's permanent. You are corrupting the protein. The idea is, and this is why it was one of the first diseases to go after, is that a lot of the proteins in our body, we need them for whatever reason. We need that protein. For TTR, as we get older, it appears that we don't need it. And so it was easy for someone who has disease from TTR to go and turn off that production. And this is near total shutdown. It's about 90% or so average. So some patients are 85, some patients are 100% shutting down of that TTR. It's one and done with no repeated dosing. Can you hear me well through this, or should I just not use it? You're okay? All right, because the acoustics are funny a little bit. And so it's one and done. So I might say, well, what is the benefit? The benefit is you get liberated from having, as far as we know, this is all investigation, it's not approved. But the theory behind it is that you no longer need a silencer or even a stabilizer maybe. You don't need to take a medication to control the origin of the disease. So that's the potential benefit. There is a second benefit that people don't talk about, because again, the chemistry is very complicated. There are patients who respond less to the traditional silencers through escape mechanisms. Your bodies are very smart. They can actually eat up some of these drugs we give you, injectable drugs. This mechanism is actually meant to not be escapable. It's a very robust, strong mechanism that can turn off that production and your body cannot escape it easily. Now, are we going to find special people? I'm looking at one here in the front row. Potentially, I don't know. But there are special people who their bodies can overcome things, correct? But as far as we know so far, that this mechanism is unlikely to be escaped. And so there might be benefit from doing that. So we're doing this study called the Magnitude trial. Let's see if I have some other slides. So Magnitude trial, we started it a while ago. We had to pause it for 4 or 5 months because there were few patients who had liver injury from the treatment. Now, this is expected. We used to tell this to all of our patients, we still do. We're doing almost surgery on the liver. We're giving you a medication, it's through the IV, you don't feel it, that's true. But we're changing how your liver will work forever. Forever. And so there is an expectation in my mind that you will that some patients might have a reaction. It happens to be very uncommon. Less than 1% of the patients got a reaction. So I personally am still very supportive of this approach because we know what can happen, we can monitor for it, and we can treat it with steroids. And usually a short course of steroids will calm down the liver. The liver is reacting back to us trying to change how it works. So that's what happens there. Now, another silencer, which is what we consider a third generation silencer. So the first generation that shuts down production from the liver were 2 drugs called patisiran and inotorsin. You might not know them because we stopped using them. We stopped using them, one because it's an infusion once every 3 weeks, and the other has side effects. So we no longer use them, generally speaking. The second generation is what you hear about more, is vutrisiran or Amvuttra and eplontorsin and or Wainua. Those are the second generation. Now this is modified from vutrisiran, from Amvuttra, to become a third generation called nucresiran. It doesn't have a commercial name yet. So nucresiran, what it does is that it suppresses TTR more than Amvuttra can, and it's dosed twice a year instead of 4 times a year. Now, I think you're starting to see a pattern that we're pushing the envelope here more and more. Will you get benefit from being 95% suppressed versus 85% suppressed? Nobody knows. But that's why we do these studies, because we want to learn. And right now, there is no matter what people tell you, there is absolutely zero evidence that you should be on more than 1 drug. That's why we want to do trials rather than throw medications at you. Because if we don't study this, we're never going to find the answer. Should you be on 2 drugs, 3 drugs? We don't know. That's why we only use 1 for most people right now. And this is the summary. You don't have to worry about the details of it. But the idea is in light chain amyloidosis, if you've heard about it this morning, we spend a long time, or others spend a long time, proving that the lower you reduce those light chains, the better that patients do. Here in Transthyretin, we don't know if you should go lower means better. We don't. And so if lower doesn't necessarily mean better in TTR, we should find that out, because then we can save all of you getting exposed to more medications. Why would we do that? And there is nothing that has no side effects. French fries has, they have side effects. And so once you study things at a very large level, you will always find the patients. So the bottom line is that we should never pursue a strategy of why not in medicine. It's always you have to prove why you're doing something, not why not doing something. Finally, and I took slightly longer than I planned to, that's that depleters. So this is a whole class. What it meant to do It does not interact or have anything to do with your stabilizers, tafamidis, acoramidis, or silencers. This is a whole different entity. What this meant to do is to incite your immune system to go and clean up what's in your heart, maybe kidneys, maybe liver, whatever, doesn't matter. Maybe joints even, we don't know. But it's an inciting medication for your immune system. It doesn't itself attack the fibroids, it actually tags them for your immune system too. Why is this important? Because as we get older, we have weaker immune systems. And so we still don't know for a fact that this strategy will work. However, we have a lot of prelim data from early phase investigation that says that we should be doing this. We should be testing this because it looks like it could work. So this is a summary table for many studies in AL and in TTR for depleters. This is one of our, not my own patient, but one of our patients in this trial of something called ATO2, which is a depleter. This is the first ever biopsy of the heart from a human being receiving one of these drugs, showing, it's very technical, but everything on the left there proves that the drug is in the heart. On the right here, we show essentially, let's see this, yeah. So what we're showing here is that the amyloid, oh, it doesn't go on the screen. So the amyloid is, let me actually do this, yeah. So this is amyloid here, also doesn't show the screen. All right, so the brown stuff is bad. And so what's happening is you show for the first time ever that when you give someone this medication, there are these giant cleaner cells that come and hug those amyloid fibers and want to remove them. So this is only one patient, obviously. So it's not like necessarily a proof that's going to work, but it's a proof that we're not giving you essentially just like water in the solution that we're using. This has already been shown by Dr. Cheng, which is the phase 1 trial of what's called Cleramicig or ALXN2220. It's the trial, it's called Depleter right now that we're running, and we're waiting for the results of Depleter, which is showing promise that the more you give of the drug, the more the patients, have objective findings of less amyloid in their hearts, for example. And their NT-proBNPs went down. A lot of you know about NT-proBNP and heard about it too. We actually are opening this trial very soon called Atriumph. It's the first ever trial of exercise and function in patients with transthyretin amyloidosis. We have run many, many trials of exercise in other diseases that look like amyloid, but not amyloid. And so what we're doing here, I really like this trial. What we're doing here is you can come on tafamidis or acoramidis, which is the oral stabilizer medication you're on. You will get a second drug called eprontorsin, which we spoke about, so you will get it anyway. So everybody gets it. And then you get 50% chance to get a third medication, which is the depleter, the thing that removes stuff from your body. You just have to be able to exercise at the beginning of the trial, even on a bike. A stationary bike is fine, you don't have to run. You have to be able to exercise at the beginning and at the end of 1 year. So a nice short trial, 1 year. You will be treated no matter what with one medication, and the second medication you have 50-50 chance of being on it. And then, about half the patients want them to do MRIs to see if we can actually remove stuff from the heart. So I really like this trial, and this is starting very, very soon. Actually, technically it started already. And then finally, I don't know if it's finally, but almost there, Cleramicig is another depleter that was made by a company called Prothena before Novo Nordisk took it over, showing some promise in the phase 2 trial that they did, showing at least it looks like it's an active drug. So we should take it to the phase 3 trial. And the phase 3 trial called Cleopatra is already ongoing. We also have it so that we can have access to people for these trials. But, my own personal favorite is the one that I just showed you, which is Atriumph, because you get access to 2 drugs, not 1. Now, Cleopatra is much longer also than Atriumph. Atriumph is 1 year Cleopatra is up to 3-4 years. And so this is another depleter. You have a chance of getting a depleter or nothing. There is no other treatment inside of this. And then finally, if you know anyone who has a gene but doesn't have the disease, we're also running trials of prevention. Why wait? If we know you have a gene that can cause a disease, why wait until you actually get the disease? Can we prevent you from having? So that's what we're doing here. I don't think we need to go through the conclusions, but I think we should be happy that a lot of things are happening and a lot of things are being developed. And, we should be proud of what we have achieved, but it's all because of you and your willingness to commit. Because it's been easy so far in amyloid that 90% plus of our trials are actually positive. This is not common. In most diseases, you don't get that high rate of positivity of trials. A lot of the trials can be negative. And so that's something to keep in mind, is that we have had a very good track record of positive trials, but as we push the envelope more and more, we might end up starting to see some neutral or negative trials because we're asking more and more and more as we proceed forward. Thank you.
Thank you, Dr. Masri. Okay, and Dr. Distad? And we'll have a Q&A panel after we're done here, all three doctors.
Thank you. Hi, everybody. Good to see you on this fine Saturday. You guys probably haven't been outside recently, so it's really nice out. So I'll have to speak quickly. So I also wanted to check in with everybody. Who in the audience knows that they have neuropathy? Okay, fair number of people. Okay, great. Thank you.
Well, I did.
So first, I'm going to touch a little bit on the background of neuropathy, and can't see that. Neuropathy is a disease of the peripheral nervous system. People have numbness, weakness, balance difficulties. It usually starts in the feet and then it works its way up to the hands over years. It's common in the US. About 0.6 of every 100,000 people have neuropathy. And in most cases, this is a gradual onset over weeks to months. And I've listed a number of causes up there. The diabetes and alcohol overuse are the most common causes in the United States. There are other hereditary causes. I don't know if you've heard of CMT, Charcot-Marie-Tooth disease, that is more common than the TTR amyloid. And when we are concerned that somebody has neuropathy, we use tests to confirm that that is involving the nerves and which nerves it involves. And that involves nerve conduction study and EMG, and that's a shock test that looks at nerve function, how it conducts, which nerves are involved, and the severity. Tissue sample is possible of the nerve, but I'll touch on that later. And then genetic disorders are, genetic testing is the other thing that we can do to look for causes of neuropathy. The majority of cases that I see don't have a genetic cause. And then this is what it looks like on nerve conduction study. On the top is you have to have a very small digit to be able to do this. So on the top is the normal that I've marked there, and that is a normal amplitude. And then if the underlying nerve is affected, which is typically what occurs in TTR amyloid, then we have what's called axonal loss, and the responses are small. And the bottom two slides show when conduction is slowed, and that's typically involving the myelin around the nerve and not typically what we see. And this is a depiction of the when the middle is the axon, the blue, and that is axonal neuropathy. That's the area that is affected as opposed to the myelin. So then I'm going to move on to transthyretin amyloid and how that involves the nerve. So this is, I'm going to talk about hereditary ATTR amyloid. And I know I saw a number of hands for people that have wild type, and the majority of this talk, I'm sorry, is really going to be focusing on the inherited form. So this is an autosomal dominant disorder, which means you have one of two genes, and that is enough to cause the disease. There's a great deal of variability. There are many different mutations, and there are a couple endemic areas like Portugal and Japan where the disease will start early, typically the third and fifth decades. The phenotype, meaning how a person presents, what symptoms they have, whether or not they actually have neuropathy, varies greatly among different mutations, but also within families and family members. About 80%, I had mentioned axonal versus demyelinating, the majority of people have the axon affected, the underlying axon, as opposed to the myelin around it. And there are many different mutations. For the TTR familial amyloid polyneuropathy, that is sometimes abbreviated FAP, this is a progressive process. We say length dependent because it starts in the feet and then progresses up over time. And often it can affect pain and temperature initially, and then later on, even years later, people develop weakness. Autonomic dysfunction can be a part of this, and symptoms that suggest autonomic dysfunction are lightheadedness with standing position change, constipation, nausea because you're easily full, the food isn't moving through as quickly. This part of the nervous system is, you can think of as it's autonomic, but it's also a lot of the automatic function. Other signs include potentially decreased sweating and urinary retention, so difficulty emptying your bladder. Again, great variability, but if the disease goes untreated, about 10 to 15% of individuals require a wheelchair in the medium to late stage, and that has a great deal of variability, what that means, and when somebody reaches that stage, and then roughly in 7 to 17 years. So we know that it is important to treat it, and the consequences are dangerous balance difficulties, falls. This is, if you were here in the morning, you heard about the AL amyloidosis. This is just a slide that points out some of the differences that we see and recognize. So when carpal tunnel occurs, the carpal tunnel can occur in both wrists, and that is a very common presentation for the TTR amyloid neuropathy. And then the other features, spinal stenosis and tendon rupture, we don't talk about those quite as often, but they're fairly common in the TTR amyloid. Val30 or Val50 is the most frequent mutation to date. Often it is early onset, and the people of Portuguese descent, people in Brazil, have onset about 33 years and often present with small fiber neuropathy or small fiber symptoms. The small fibers convey pain, temperature, and touch, and autonomic symptoms are fairly common that I'd mentioned, lightheadedness, decreased sweating, gastrointestinal symptoms. The late onset variants are seen coming more out of Sweden and some out of Japan. Japan has both early onset and late onset phenotypes with a mean age of onset of 60 years. And the sensory loss more commonly affects all of the fibers. So that would be the pain, temperature, but also joint position sense. We test for vibration as a measure of this, and that correlates with somebody's balance. Some of these late onset can progress more rapidly, and there are a number of mutations that fit into this late onset. I've listed a couple that of heritage from Italy, and then some that have more of a fast progression. And I had mentioned bilateral carpal tunnel syndrome. Sometimes people have surgery for that years, 10 years, even before we hear about any signs of neuropathy. So it's an important thing to recognize, but it's very common in the population, so it doesn't mean everybody with carpal tunnel has amyloid neuropathy. This is just a picture of the carpal tunnel. The nerve runs through this small space, and there are tendons around the nerve. The nerve is the yellow. I've listed a number of mutations that are commonly found to be associated with early onset carpal tunnel that precedes the diagnosis of the TTR amyloid by years. And the biopsies, they don't biopsy the nerve because that would cause permanent damage. But when they do the biopsy, they test the connective tissue around it. This is contrasting the AL amyloid on the top, but the bottom is what I want you to focus on, which is the ATTR variant hereditary amyloidosis sourced in the liver that produces the TTR tetramers. And when you have that mutation in there, that's when the TTR, the transthyretin, becomes misfolded and then coalesces, and then you get these aggregates. And ultimately, as you look out on the far right of the screen, the red shown in the middle of the screen affects the nerve. It's actually within the nerve itself, within the nerve fibers, around the nerve fibers, and then it's also on the bottom. You can see the red slashes that look like nests. That's all amyloid in the connective tissue around the nerve. I talked a little bit about evaluation. Neurological examination is very valuable to determine if somebody with symptoms of numbness, tingling, burning has findings on their examination for neuropathy. Does it look like it's more the peripheral nervous system? Is it only affecting the entire left side of the body, in which case we're thinking more central nervous system? I mentioned nerve conduction study. Those are commonly done to look, are the large fibers involved? And tissue for biopsy, I listed the different resources like abdominal fat pad aspirate, skin biopsy, the gastrointestinal tract have probably a higher yield than doing something like sural nerve biopsy. You want to know the sural nerve is involved. You want to know it's kind of actively involved rather than end stage, and then it's patchy. But this is an important question in trying to identify, is the nerve involved by the TTR amyloid? And fortunately, we have a lot of generous companies that are sponsoring genetic testing. So genetic testing is available and has been for many years for free. With currently, we're just doing a swab of the mouth for the genetic test variants. This is the demonstration on the left of the red, which is called Congo red, positive staining on these H&E sections of the nerve. On the right is the apple green birefringence, bipolarized light, and you can see on the bottom going vertically is where it's involved in the nerve. The top is a section of a cross-section of a muscle showing the amyloid there. And then moving on to management and treatment. So you've heard a lot about treatment in neuropathy. I'm going to just mention other things we do for management. Supportive bracing, so splints at the wrists are used for carpal tunnel, sometimes early on before somebody looks at surgery, depending on the severity. And the surgical decompression for carpal tunnel syndrome, of course, can be undertaken. Physical therapy is important, particularly to work on balance, maybe core strengthening if needed. And then being cautious, we inform people they need to look at their feet and check them, be careful, keep their feet protected, identify where you're walking. If you have symptoms of neuropathy, numbness, you can't feel things as well. Medications can be used to control symptoms, and then treatment for the TTR amyloid itself. And just a summary of some of the things that we use in neuropathy. If pain is present, we use gabapentin, pregabalin, duloxetine, venlafaxine. Those are medications that block the pain. Topically, if you want to avoid systemic side effects, capsaicin is available over the counter. That's cayenne, lidocaine, and then there are compounds, like from a compounding pharmacy that can be trialed. We don't have great data for benefit of those, but they certainly avoid systemic side effects. If you have orthostatic hypotension, lightheadedness with standing, using thigh-high, high compression stockings, increasing fluid and salt if it's not contraindicated, are ways to modify symptoms from that. And then there are medications for GI symptoms and changing the way you eat. And I've already mentioned for balance difficulty, physical therapy. You've heard a lot about the TTR gene silencers. These reduce the protein by degrading the TTR. The two mechanisms, one is the antisense oligonucleotide, that's the inotersen and eplontersen, and they degrade the mRNA via a nuclear RNase H1. And then there are small interfering RNAs, patisiran and vutrisiran. And I would emphasize the difference here is we have data for neuropathy and we have data for cardiomyopathy with TTR amyloid, so that can be confusing. The trials for neuropathy, the NeuroTTR, the TTR transform, the Apollo for patisiran, and then Helios A for vutrisiran, all met their primary endpoint for benefit compared to placebo. And I've put these on a graph, a table, just to give you a sense of, I look at, how many people were involved in this trial. Is it significant? How long was the trial? And then the measurements, these are the neuropathy impairment score, polyneuropathy disability score, and familial amyloid polyneuropathy scale. And then these are the frequencies. Dr. Masri pointed out that really we're talking about mostly vutrisiran because you only have to take it under the skin every 3 months, and eplontersen, which is you can self-inject, and that's monthly. The patisiran, I'll mention quickly, 56% of patients had improvement in this mNIS+7 score. That's what has been used as a standard in all of these placebo-controlled trials. And 56% of patients had improvement in the score versus 4% in the placebo. And in the group that had no improvement on that scale, of all of those, 39% had a median change from the baseline in this score at 18 months, better score than all of the placebo group. These are a little bit different, but the graph is a nice way to show the difference. This is vutrisiran and Vutra, and this is the historical placebo control. The higher the score for this, this is the mNIS+7 score that I've been mentioning. The higher the score, the worse the outcome. You can see everyone started at a baseline of 0, so this is a mean change, and the individuals treated over these 18 months had hardly any change, and that's a mean of all of the individuals in the trial. And then this is for eplontersen. All these drugs very effectively reduce the TTR, and that's what the top graph is. The bottom graph, the blue shows you the historical placebo, and then the eplontersen you can see on the bottom is the mNIS score, which is the neuropathy impairment score, looks at symptoms and examination. And then on the right is the quality of life. So what was the meaning for individuals that were on it? And both definitely are different than the historical placebos. And then just to mention these, the CRISPR-Cas9 that was mentioned is also being looked at in the trial involves evaluation of neuropathy outcome in the sense they're looking at a 6-minute walk distance. And in this group, this is only a phase 1, so this is only 36 individuals just to see if it was safe. They did have a slight improvement in their mean 6-minute walk distance. And I would remark on improvement is something because we're just stopping the TTR production. So something's going on where gradually over time, over 12 to 18 months, we're seeing that the TTR amyloid's no longer being laid down in the nerve, but people are actually improving without evidence that we're really even removing it from the nerve. So that is significant. And then there are the newer antibody-mediated amyloid removal therapies that Dr. Masri also mentioned. Ongoing questions for us. TTR amyloid that is wild type. What does that mean in neuropathy? And in general, there's not a lot of evidence that TTR wild type involves the nerves. But my questions are, is it just because we haven't identified those mutations? Is it really different? And we're stuck with, we just don't have data on it. And fortunately, because in cardiology and cardiomyopathies, they're really looking at this, and they're including individuals with the TTR wild type. So we might get kind of an indirect answer. If you do have the wild type TTR and you have neuropathy symptoms, it is important to try to identify, do an evaluation for any other possible cause of that neuropathy. Tafamidis comes up in neuropathy. It's not FDA approved in the United States. The trial that showed benefit was in Europe. It was only in the Val-30 Met. And actually, for neuropathy, it didn't show improvement. There was no difference in these scores. And so currently, I don't make any recommendations for the tafamidis. And you have heard this is challenging because we've got potentially two different drugs that the insurance companies do not believe should be used together based on cardiac studies only. I did include here that their wild-type TTR, of the individuals, there were 18 out of some 400 that were identified to have neuropathy. 4 of those 18 agreed to undergo a biopsy, and 2 of those 4 people had TTR amyloid on the biopsy. So there is some correlation. Maybe it's very tiny, but more to come on that. And thank you for your attention.